everyone. I'm Dr. Chinyere Ugoji, MD, MBA, with interest in healthcare, education, leadership, and public health, and graduate medical education, with application through the electronic residency application system 2015, and participants in the American Medical Association mock interview session. Welcoming you to Dr. Chiquito Mentoring Iridescent Education Collaborative Global Ustream YouTube show. I would like to share this quote with you. I also forgot to mention, I'm also in clinical practice currently. So I would like to share this quote with you. At each and every juncture of our history, somebody has been audacious enough to say, we could do better, and most often than not, it's been young people who have done it. President Barack Obama, February 2nd, 2007. This program will mentor and cultivate young leaders of today and tomorrow, and I am glad that they will have this opportunity to serve. I look forward to working with those who are selected to participate, and I want to commend all who apply for their desire to help through public service to forge a brighter future for our country. President Barack Obama, May 22nd, 2014. Education is the key to success for so many kids, and my goal specifically is to reach out directly to young people and encourage them to take charge of their futures and complete an education beyond high school. First Lady Michelle Obama, January 16, 2014. Education is indispensable to the success of every individual and is the motivating factor behind my graduate medical education curriculum review and interest in the Reach Higher initiative by the First Lady Michelle Obama, inspired by this quote by the First Lady Michelle Obama, and a determination to focus on education. Dr. Chinyere Ugoji, MD, MBA, October 25th, 2014. I would also like to share some more quotes by some healthcare leaders. I had the opportunity to work with Chinyere Ugoji during the period July 7th to July 31st in my family practice and pediatric office at the professional office at St. Elizabeth Hospital, Chicago, Illinois. She worked under my supervision as an extern seeing adult patients and pediatric patients. She did case presentations, performed vital signs and weights, and presented various topics. I was impressed by her history-taking skills and ability to quickly establish a rapport with the patients. She participated actively in combining the signs and symptoms of various diseases to arrive at differential diagnosis and treatment regimen. She exhibited outstanding clinical knowledge. She made accurate clinical observations and came up with good management plans. Chinyere Ugoji came across as a very hardworking, reliable, and intelligent young lady who will make a very good resident in any residency program. She was also able to develop a good rapport with the pediatric patients as well as adult patients. She exhibited professional behavior and was willing to go the extra length to learn and to help others. She also exhibited excellent interpersonal skills towards her colleagues and office staff. She was viewed with respect and affection by her colleagues, staff, and patients. I have no doubts that she would excel in residency. I think she would make a good physician. An excerpt from a letter of recommendation written by Dr. Saida X. Zahidi, MD. I would also like to share another quote with you. I have had the opportunity of working with Ms. Ugoji as her attending physician during her family medicine clerkship. During the 8 weeks of the clerkship, my interaction with Ms. Ugoji was quite enjoyable. She was a hard-working student who was eager to learn. She impressed me with her maturity, ability to be a team player and to go the extra mile. Her personality was very pleasant and she was well liked by her staff. Ms. Ugoji always carried out her assignments and conducted herself in a professional manner. She was well respected by the other students and was a great example for the other students to follow. I was very impressed with her enthusiasm for learning and improving her clinical skills. Her clinical presentations were very good, and she presented them in a timely manner. Her write-ups were well written and very legible. Her fund of knowledge was solid for her level of training. And her presentations were an excerpt from a letter of recommendation by Dr. Otis S. Paul Jr., MD. I would also like to share another quote with you. Um, Miss Ugoji served in 1 month of ophthalmology rotation in this office in 2006. She has shown herself to be an outstanding individual with a keen intellectual grasp of medical issues, combined with the compassion necessary to care for patients on a long-term basis. Many ophthalmology patients are elderly and or infirm, and I was impressed with her ability to deal with this population. With a quiet yet confident and competent demeanor, she's able immediately to put patients and staff at ease. She works well with ancillary personnel and is intellectually demanding. After a time in the office, she was totally familiar with workup and testing procedures, and she carried out her duties in an exemplary fashion. She also maintained a steady study schedule related to her monitored cases and diseases. I believe Ms. Ugoji will become a fine physician, and she has the qualifications to enter any specialty or field in which she may have an interest. An excerpt from a letter of recommendation by Dr. Jetty Bonnet, MD. I would also like to share another quote with you. Um, I had the opportunity to work with Ms. Ugoji as one of my students during February 2006 to March 2006. Ms. Ugoji participated in a surgery rotation with me at Northside Main Campus and Emory Crawford Long Hospital in Atlanta, Georgia. Her duties involved physical examinations, clinical assessments, and case presentations. Ms. Ugoji showed tremendous aptitude in grasping medical concepts, making associations and applying various theories. Her keen perceptiveness and diligence as a student allowed her to make valid judgments and assessments when called upon. As part of her evaluation, Ms. Ugoji was required to present case presentations during our didactic sessions before and after patient examinations. I was impressed with her clinical acumen. She made accurate clinical observations and formulated good management plans. In addition, Ms. Ugoji had excellent rapport with the patients. She was not she was not only able to attain the necessary information from them, but also to put them at ease very quickly. Her excellent interpersonal skills extended also to her colleagues and my office staff. She was well respected by her peers and others she came in contact with in my office. Besides the requisite skills Ms. Ugoji possesses, she also brings a compassionate spirit and insatiable desire to succeed. I support her for residency training without hesitation. An excerpt from a letter of recommendation from Dr. O. Bruce Case, MD, FACS. I would also like to share another quote with you. Dr. Chinyere A. Ugoji, MD, was noted to be kind and personable. An excerpt from a letter of recommendation from Dr. Kimberly Baker Janor, Program Director Emeritus, Henry Ford Internal Medicine Residency Program, Detroit, Michigan. I wish you good luck in your future endeavors. An excerpt from a letter addressed to Dr. Chinyere A. Ugoji, MD, MBA from Dr. Janet Albers, MD, Program Director, Southern Illinois University School of Medicine, Family Medicine Residency Program. All these letters can be found in the secure letter of recommendation portal with the electronic residency application service. So today we're going to be talking about the commonly encountered graduate medical education questions encountered on the expedition for the perfect fit for the achievement of your graduate medical education goals. And the graduate medical education question for the interviewer, which could be the program director, the faculty member, a resident, a medical student, or a staff, would be: is there a feedback structure that allows for the resident to evaluate the program's curriculum? This could be polls, this could be written and verbal feedback. Some feedback and evaluation which I've done in my career include feedback in medical school to American International School of Medicine, Guyana, and also feedback on intern orientation section of the curriculum to the program director, Dr. Kimberly Baker Janor, MD, at Henry Ford Internal Medicine Residency Program as an intern. Feedback on research on the average length of stay of inpatients of inpatients at Southern Illinois University School of Medicine, Springfield, Illinois, to the program director and the faculty member, Dr. Janet Albers, MD, and also Dr. Mike Hodinda, MD. Feedback in patient care and grand rounds at Harris Fort Worth Methodist Hospital, Fort Worth, Texas, Huntsville Family Medicine Residency Program, Huntsville, Alabama, and St. Mary and St. Elizabeth Family Medicine Residency Program, Chicago, Illinois. So going to the next section, which would be the question for the interviewer, for the interviewee, which could be you or me, even as we are on the expedition for the graduate medical education program for our goals would be how do you handle confrontations? And my answer to that would be communication is the key to handling confrontation successfully, utilizing a good understanding of the personality, the role, and the perspective of the team. And with that, I would also want to share my graduate medical education curriculum review with you. So the 6 core competencies for every physician include medical knowledge, patient care, professionalism, interpersonal communication, practice-based learning, and system-based practice. So those are the core competencies that every physician should acquire through medical school, through to residency. To residency. And then the advanced cardiac advanced cardiac life support algorithms are also part of the intern package that you also get as an intern, and also as you you also learn in medical school. Some important points about the ACLS algorithm for adult cardiac arrest include the CPR quality. You have to an important point includes you have to push hard, more than 2 inches, 5 cm, and fast, more than 100 per minute, and allow complete chest recoil. Minimize interruptions in compressions. Avoid excessive ventilation. Rotate compressors every 2 minutes. If no advanced airway, then you perform 30:2 compression ventilation ratio. For the quantitative waveform capnography, if the PETCO is less than 10 mm mercury, then attempt to improve CPR quality. For the intra-arterial pressure, if relaxation phase, that's the diastolic pressure is less than 20 mm mercury, then attempt to improve the CPR quality. For return of spontaneous circulation, ROSC, pulse and blood pressure is important. Abrupt sustained increase in PETCO, which is typically more than 40 mm mercury. Spontaneous arterial pressure waves in intra-arterial monitoring. For shock energy, it normally comes in two categories, biphasic and monophasic. So for biphasic, the manufacturer recommendation is 120 to 200 joules. If unknown, then use the maximum available. The second and subsequent doses should be equivalent, and higher doses may be considered. For the monophasic, it should be 360 joules. For drug therapy, it includes epinephrine, vasopressin, and amiodarone. For epinephrine IV or IO dose, it's normally 1 milligram every 3 to 5 minutes. For vasopressin, the IV or IO or intraosseous dose, it will be 40 units, which can replace the first or second dose of epinephrine. For amiodarone, which is given intravenously or interosseously, the first dose will be 300 milligram bolus, and then the second dose will be 150 milligram. I'm fixing some technical issues. I apologize for the for the break in transmission. Yeah, so for the shock energy by physic, manufacturer recommendation is normally 120 to 200 joules. If unknown, then use the maximum available. For the second and subsequent doses, they should be equivalent and higher doses may be considered. Monophasic is 360 joules. For drug therapy, epinephrine IV or IO dose is 1 milligram every 3 to 5 minutes. We already talked about it earlier. Vasopressin IV or IO dose is 40 units, which can replace the first or second dose of epinephrine. For amiodarone is first dose 300 milligram bolus, second dose 150 milligram, and that's giving IV or IO doses. For advanced airway is supraglottic advanced airway or endotracheal intubation with form capnography to confirm and monitor ET2 placements, and you want to ensure 8 to 10 breaths per minute with continuous chest compressions. That's the goal. I've had experiences with these in my career. So for the reversible causes, include the 5 H's and the 5 T's, which include hypovolemia as the first H, hypoxia as the second H, hydrogen ion acidosis as the third H, hypothermia as the fourth H, and then hypovolemia. So that's hypovolemia, hypoxia, hydrogen ion acidosis, or hyperkalemia, and then hypothermia. And then the 5 T's would be tension, pneumothorax, cardiac tamponade, thrombosis, coronary thrombosis, and thrombosis, pulmonary thrombosis, and toxins. So that's tension, pneumothorax, tamponade, cardiac tamponade, toxins, thrombosis, pulmonary, and thrombosis, coronary. So for the algorithm, the first step is shout for help or activate emergency response. And then what's the next step? If you answer start CPR, give oxygen, attach monitor or defibrillator, then you're right. And then the next step would be reading, to check if the reading is shockable. If it's shockable, that's normally VFib or VTAC, and we'll discuss that later on. Then you shock. And then after that, you do CPR for 2 minutes, ensure intravenous or interosseous access, and then you check again if the reading is shockable. If it's shockable, then you do CPR for 2 minutes, and then you do epinephrine every 3 to 5 minutes. Consider advanced airway capnography. Then check if the reading is shockable. If it is, then you shock. And then you give CPR for 2 minutes, and then you give amiodarone. Then also treat the reversible causes, which we just mentioned a few minutes ago. If it's not shockable at the first step, well, you go to go to you check for signs of return of spontaneous circulation, and then go um, 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 to giving CPR every 2 minutes, ensuring intravenous or interosseous access, and epinephrine every 3 to 5 minutes. Consider advanced airway or capnography. Um, and then at the point where after giving CPR for 2 minutes and giving epinephrine every 3 to 5 minutes and considering advanced airway and capnography, and yeah, if the rhythm is not shockable, then you still check for signs of spontaneous circulation, and then also do a post cardiac arrest care. So after so, but then if the rhythm is not shockable, we already discussed if the rhythm is shockable, then you want to do, then it means that the patient is probably in asystole or PEA. So that takes you to step 10. You do CPR for 2 minutes, then you ensure intravenous or interosseous access, give epinephrine every 3 to 5 minutes, consider advanced airway or capnography, and then check if the rhythm is shockable. If it's not shockable, that takes you to step 11. So CPR 2 minutes and then treat the reversible causes. If the rhythm is shockable, at this point, after checking, then you go to step 5 or 7. Step 5 is shocking, and is yeah, step 5 or 7 is shocking. And then if the rhythm is not shockable, then you go to checking for signs of return of spontaneous circulation or post cardiac arrest care. So the ACLS cardiac arrest circular algorithm is for adult cardiac arrest. Some important points include the CPR quality. So you want to push hard, more than 2 inches, 5 cm, and fast, more than 100 per minute, and allow complete chest recoil. Minimize interruptions and compressions. Avoid excessive ventilation. Rotate compressor every 2 minutes. If no advanced airway, then you perform a 30:2 compression ventilation ratio. Quantitative waveform capnography. If PETCO is less than 10 mm mercury, attempt to improve CPR quality. For intra-arterial pressure, if relaxation phase diastolic pressure is less than 20 mm mercury, attempt to improve the CPR quality. For return of spontaneous circulation, ROSC, you want to check the pulse and blood pressure. You want to check for abrupt sustained increase in PETCO, typically more than 40 mm mercury. Spontaneous arterial pressure waves with intra-arterial monitoring. The shock energy comes in two forms: biphasic, which is manufacturer recommended, 120 to 200 joules. If unknown, use maximum available. Second and subsequent doses should be equivalent, and higher doses may be considered. The monophasic is 360 joules. For drug therapy, is epinephrine intravenously and interosseously 1 milligram every 3 to 5 minutes. For vasopressin, intravenously interosseously is 40 minutes, which can replace the first or second dose of epinephrine. For amiodarone, intravenously or interosseously is first dose 300 milligram bolus and second dose 150 milligram. For advanced airway, you have supraglottic advanced airway or endotracheal intubation, waveform capnography to confirm and monitor ET2 placements. Give 8 to 10 breaths per minute with continuous chest compressions. And we already talked about the reversible causes, the 5 H's and the 5 T's, which include hypovolemia, hypoxia, hypothemia, hydrogen ion acidosis, hypo or hyperkalemia. And then the 5 T's, which include trauma, toxins, cardiac tamponade, thrombosis, coronary thrombosis, and thrombosis, pulmonary thrombosis. and toxins. And so the steps include shouting for help and activating emergency response. You start CPR, give oxygen, attach the monitor or the defibrillator. Then you check for reading, and then you if the patient is in VFib or VTAC, then you shock, and keep on giving continuous CPR, monitor CPR quality, and then keep on giving continuous CPR. After checking the reading, you now also give the drug therapy. That's the intravenous or intraosseous access. You ensure intravenous and intraosseous access. We give epinephrine every 3 to 5 minutes. We also give amiodarone for refractory VFib or VTAC. Consider advanced airway, quantitative waveform capnography, and treat the reversible causes. So for the bradycardia algorithm, which is defined as a heart rate less than 60 beats per minute. For adult bradycardia with pulse, we assess the appropriateness for clinical condition. Normally, the heart rate is typically less than 60, less than 50 per minute if bradyarrhythmia. The range is normally 50 to 60. So you identify and treat the underlying cause. You maintain a patent airway, assist breathing as necessary, oxygen if hypothermic, then cardiac monitor to identify reading, monitor blood pressure and altimetry. You also ensure IV access. You also do a 12 lead EKG if available. Don't delay therapy. If there's persistent bradyarrhythmia causing hypotension, acutely altered mental status, signs of shock, ischemic heart discomfort, acute heart failure, which is step 3, well, you give atropine. If atropine is ineffective, then you do transcutaneous pacing or dopamine infusion or epinephrine infusion. Then consider consultation and transvenous pacing. If at step 3 there's no persistent bradyarrhythmia causing all the symptoms of bradyarrhythmia, then you monitor and observe. For the doses and the details for bradyarrhythmia, atropine IV dose, first dose is 0.5 milligram bolus. Repeat every 3 to 5 minutes with a maximum of 3 milligram. Dopamine IV infusion and epinephrine IV infusion. For dopamine is 2 to 10 mcg per kilogram per minute. And for epinephrine IV infusion is 2 to 10 mcg per minute. So the tachycardia algorithm for adults tachycardia with pulse. Number 1 is to assess the appropriateness for clinical condition. The heart rate typically is more than 150 per minute if tachyarrhythmic. Then identify and treat underlying causes. Maintain a patent airway, assist breathing as necessary. Give oxygen if hypothermic. Also hook up a cardiac monitor to identify reading, monitor blood pressure and altimetry. So that takes you to step 3. If there's persistent tachyarrhythmia causing hypertension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, then you go to step 4, which is synchronized cardioversion. Consider sedation. If regular narrow complex, consider adenosine. If there's no persistent tachyarrhythmia, then you check for wide QRS complex, which is more than 0.12 seconds. If there's wide QRS complex, then you go to step 6, which is intravenous access and 12 lead EKG if available. Consider adenosine only if regular monomorphic, and then consider anti-arrhythmic infusion, and consider expert consultation. If there's no wide QRS complex, and then you go to step 7, which is IV access and 12 lead EKG if available. Vagal maneuvers, adenosine if regular, beta blocker or calcium channel blocker, and consider expert consultation. So for the for the doses and details, you want to do synchronized cardioversion, which is with the initially recommended doses. Narrow regular is 50 to 100 joules. Narrow irregular is 120 to 200 joules biphasic or 200 joules polyphasic. For wide regular, you can give 100 joules. For wide irregular, you can do a defibrillation dose not synchronized. For adenosine IV dose, first dose is normally given as a 6 milligram rapid IV push, followed with normal saline flush. Then the second dose is given as a 12 milligram if required. For antiarrhythmic infusions for stable wide QRS tachycardia, you want to give procainamide IV dose 20 to 50 milligram per minute until arrhythmias suppressed. Hypotension ensues, QRS duration increases more than 50%, maximum dose 17 milligram per kg is administered. Then for the maintenance infusion, you want to give 1 to 4 milligram per minute and avoid if prolonged QT or CHF. The amiodarone IV dose, first dose is 150 milligram over 10 minutes and repeat as needed if VT recurs, followed by a maintenance infusion of 1 milligram per minute for first 6 hours. For sotalol IV dose, you want to give 100 milligram, 1.5 milligram per kg over 5 minutes and avoid if prolonged QT. For the post-cardiac arrest care algorithm, which is where we are right now, some important points about this algorithm includes the doses and the details. So for ventilation and oxygenation, avoid excessive ventilation. Start at 10 to 12 breaths per minute and titrate to target PETCO2 of 35 to 45 mmHg. When feasible, titrate FiO2 to minimum necessary to achieve SpO2 more than 94%. IV bolus, you normally give 1 to 2 normal saline or lactated ringers. If inducing hypothermia, you may use 4 degrees centigrade fluid. Epinephrine IV infusion, you give 0.1 to 0.5 mcg per kg per minute. In a 70 kg adult, that's normally 7 to 35 mcg per minute. Dopamine IV infusion, you normally give 5 to 10 mcg per kg per minute. For non-epinephrine IV infusion, you give 0.1 to 0.5 mcg per kg per minute. In a 70 kilogram adult, that equals out to 7 to 35 mcg per minute. And then also the reversible causes are some things that you have to keep in mind. That includes hypovolemia, hypoxia, hypothermia, hypo and hyperkalemia, and then also and hypoxia, and also hydrogen ion acidosis. And then the 5 T's, which includes tension, pneumothorax, toxins, coronary coronary thrombosis, pulmonary thrombosis, cardiac tamponade. So the steps in the adult immediate post-cardiac arrest care include number 1, which is return of spontaneous circulation, ROSC. Then the optimized ventilation and oxygenation, maintain oxygen saturation more than 94%. Consider advanced airway and waveform capnography. Do not hyperventilate. Treat hypertension. That's an SBP less than 90 mmHg. And you can do that with giving IV or IO bolus, doing a vasopressor infusion. Consider treatable causes and also doing a 12 lead EKG. Then you go to step number 4, which includes follow commands. Checking if the patient follows commands. If the patient doesn't follow commands, then you consider induced hypothermia. If the patient follows commands, then you do you check for an ST elevation MI or high suspicion of acute MI. If the patient has that, then you consider coronary reperfusion. If the patient doesn't have that, then you consider advanced critical care. So for the doses and for the details, ventilation and oxygenation, you want to avoid excessive ventilation. You want to start at 10 to 12 breaths per minute and titrate to target PETCO2 of 35 to 40 mmHg. When feasible, titrate FiO2 to minimum necessary to achieve SpO2 of more than 94%. IV bolus, you want to give 1 to 2 liters normal saline or lactated bringers if you're using hypothermia. You may use 4 degrees centigrade fluid. For epinephrine IV infusion, you want to give 0.1 to 0.5 mcg per kg per minute in a 70 kilogram adult. In a 70 kilogram adult, you that equals out to 7 to 35 mcg per minute. So you want to treat the reversible causes, which we already talked about: hypovolemia, hypoxia, hydrogen ion acidosis, hypothermia, and hypo or hyperkalemia, and then also give tension pneumothorax, and then also the 5 T's. That's tension pneumothorax, cardiac tamponade, toxins, coronary thrombosis, and cardiac thrombosis. So that brings us to the next algorithm, which is acute coronary syndromes algorithm. So for acute coronary syndromes, if there's the first step is to check if their symptoms are suggestive of ischemia or infarction. Well, for number two, is checking for EMS assessment and care and hospital preparation. So monitor, support ABCs, be prepared to provide CPR and defibrillation, administer aspirin, and consider oxygen, nitroglycerin, and morphine if needed. Obtain a 12-lead EKG if there's ST elevation. Notify receiving hospital with transmission or interpretation. Note time of onset and first medical contact. Notified hospital should mobilize hospital resources to respond to ST elevation MI. If considering pre-hospital fibrinolysis, use the fibrinolytic checklist. Then, step number 3 is concurrent ED assessment, which should be less than 10 minutes. So you check vital signs, evaluate oxygen saturation, establish IVSS, perform a brief targeted history and a physical examination, review or complete fibrinolytic checklist, check contraindications, obtain initial cardiac marker levels, initial electrolyte and coagulation studies, obtain portable chest X-ray for in less than 30 minutes. And then also for immediate ED general treatment, if oxygen saturation is less than 94%, then start oxygen at 4 liters per minute and titrate. And then aspirin should be given in doses of 160 to 325 milligram, if not given by the EMS. Nitroglycerin is normally given sublingually or as a spray. Morphine IV if discomfort is not relieved by the nitroglycerin. For the EKG, and then the next step is step number 4, which is the EKG interpretation. And then that takes you to step number 5. And that depends on what you see on the EKG, what the EKG tells us. So if there's ST elevation on new or presumably new left bundle branch block, strongly suspicious for injury, that's ST elevation MI, then you want to start adjunctive therapies as indicated. Do not delay reperfusion. Then also check time from onset of symptoms less than 12 hours. If it's less than 12 hours, then you want to go for the reperfusion goals, which is step number 8. So the reperfusion goals is therapy defined by patient and center criteria. That's a door to balloon inflation, PSEG goal of 90 minutes, door to needle fibrinolysis goal of 30 minutes. Then step number 9 is ST depression or dynamic T-wave inversion, visualized on the EKG. So that's strongly suspicious for ischemia. So that's high risk unstable angina or non-ST elevation MI. So that takes you to step number 10. So you check if the troponin is elevated or if the patient is a high risk patient. You have to do the risk stratification. We'll talk about that later on. Then consider early invasive strategy. If refractory ischemic chest discomfort, recurrent or persistent ST deviation, ventricular tachycardia, hemodynamic instability, and signs of heart failure. Then with that, you go to step number 11. Start adjunctive treatments as indicated. That's giving nitroglycerin, heparin, unfractionated heparin, or low molecular weight heparin. Consider beta blockers. Consider clopidogrel. Consider glycoprotein 2B or 3A inhibitor. And then that takes you to step number 12. So you admit to monitored bed, assess risk status, consider continue aspirin, heparin, and other therapies as indicated. And that includes ACE inhibitors or ARBs, HMG-CoA reductase inhibitors. That's starting therapy, which is recommended with high level of evidence. And then also, if they are not at high risk, then you want to get cardiology to risk stratify. So if there's abnormal or non-diagnostic changes in ST segment or T wave on the EKG, that's from step number 4, that takes you to step number 13. So that's low or intermittent risk ACS. So you consider admission to ED chest pain units or to appropriate bed and follow. The serial cardiac markers, which include troponin, repeat EKG or continuous ST segment monitoring. Consider non-invasive diagnostic testing. And then that takes to step number 15. So if they develop one or more clinical high-risk features, dynamic EKG changes consistent with ischemia and troponin elevated, if those signs are there, then you go to step number 10, which is checking for elevation of troponin or high-risk patients with risk stratification. If those signs are not there, then you check for abnormal diagnostic non-invasive imaging or physiologic testing. If that's not there, then you go to step number 17 from step number 16, which we just discussed a few minutes ago, to check for any evidence of ischemia or infarction by testing, and then you can now discharge with follow-up. So for the patient with suspected stroke, the steps include identifying signs and symptoms of possible stroke, activating emergency response, the critical EMS assessment and actions include supporting ABCs, give oxygen if needed, perform pre-hospital stroke assessments, establish time of symptom onset when the patient was last normal, doing a triage to stroke center, alerting the hospital, then checking the glucose if possible. And then if then that takes you to step number 3. So that's immediate general assessment and stabilization. Assess ABCs, vital signs, provide oxygen if hypoxemic, obtain IV access and perform laboratory assessments, check glucose, treat if indicated, perform neurologic screening assessments, activate the stroke team, other emergency CT scan or MRI of the brain, and obtain a 12-lead EKG. And then that takes you to the next step, which is step number 4. So that's immediate neurologic assessment by stroke team or designee. You also review the patient's history, establish time of symptom onset or last known normal, perform the neurologic examination. We will talk about that later on. The NIH stroke scale or the Canadian neurologic scale. Then that takes you to step number 5. You want to see if the CT scan shows a hemorrhage. If there's no hemorrhage, then it could probably be an acute ischemic stroke. You consider fibrinolytic therapy. Check for fibrinolytic exclusions. Then repeat the neurologic examination. Check if the deficits are rapidly improving to normal. That's step number 6. If there's hemorrhage, that takes us to step number 7. So you consider neurologist and neurosurgeon. Consider transfer if not available. And then with that takes us to step number 11. So you begin stroke or hemorrhage pathway, admit to stroke unit or intensive care unit. With step number 6, after considering acute ischemic stroke and considering fibrinolytic therapy and checking the exclusions, repeating the neurologic examination, You want to check if the patient still remains a candidate for fibrinolytic therapy. So that's step number 8. So if the patient is a candidate, then that takes it to step number 10. So you want to review risk and benefits with patients and family. If acceptable, then you give RO-TPA, no anticoagulants or antiplatelet treatment for 24 hours. That takes it to step number 12. So you want to begin post-RO-TPA stroke pathway, aggressively monitor, um, check BP per protocol for neurologic deterioration, emergent admission to stroke unit or intensive care unit. If the patient is not a candidate, then you want to administer aspirin, then also begin the stroke or hemorrhage pathway, then administer to stroke unit or intensive care unit. So the NINDS time goals for ED arrival within 10 minutes. That's a goal, and then the next goal is for ED arrival within 25 minutes, within 45 minutes, and also within 60 minutes, and then also the stroke admission within 3 hours. So we'll discuss the ACLS code drugs. So for the first drug includes adenosine or adenocard. That's normally used for narrow PSVT or SVT. That's with wide QRS tachycardia of uncertain cardiac origin. So you give 6 milligram followed by 12 milligram in 1 to 2 minutes. How do you administer that? Administration is rapid IV push close to the hub, followed by a saline bolus. For amiodarone, that's normally for VFib or pulseless VTAC. That's VTAC with a pulse. So that may be used for rate control of WPW or atrial tachycardias. For the dosage, that's 300 milligram IVP for cardiac arrest. Consider repeating with 150 milligram in 3 to 5 minutes. And then also give 150 milligram over 10 minutes for stable VT. May repeat 150 milligram every 10 minutes as needed for a cumulative dose of 2.2 IV in 24 hours. Slow infusion 360 milligram IV over 6 hours with a maintenance of 540 milligram over 18 hours. And that's 0.5 milligram per minute. How do you administer that? Well, you draw up with filtered needle, administer drip with filtered tubing. GTT infusion mix should be 900 milligram per 500 DSW. That's 1 milligram per minute, which equals 23.3 cc per hour, 0.5 milligram per minute, which equals 16 cc per hour, and half-life is up to 40 days. For atropine, that's actually used to treat symptomatic sinus bradycardia. So that's I'm giving it in dosages of 0.5 milligram IV every 3 to 5 minutes for bradycardia, not to exceed 3 milligrams. For the tracheal administration, that's giving 2 to 3 milligram diluted in 10 cc normal saline. Administration is do not give less than 0.5 milligram IV. Maybe giving IV, IO, or ET. Does not work with heart transplant patients due to denervation. For calcium chloride, that's for known or suspected hyperkalemia. That's impacting on renal function. Well, you and also for hypocalcemia after multiple blood treatments, and then antidote for calcium channel blockers or beta blocker overdose. The dosage is actually 8 to 16 milligram per kg IV for hyperkalemia and calcium channel blocker overdose. Administration do not mix with sodium bicarbonate. For dopamine, that's actually used for indications of hypotension with signs and symptoms of shock or bradycardia. For the dosage, that's actually mixed 400 milligram per 250 in D5 water in a dose of 2 to 10 mcg per kg per minute. And for administration, that's a good intravenous line. to avoid extravasation and infiltration, and also do not mix with sodium bicarbonate. For epinephrine, that's used for indications of cardiac arrest, VFib, pulseless VTAC, asystole, and PEA. For symptomatic bradycardia, for severe hypotension, and for anaphylaxis. Um, for the dosage, you want to give that in cardiac arrest, 1 milligram of the one in 10,000 administered every 3 to 5 minutes, and follow each dose with an IV flush. Um, Bradycardia or hypertension, you want to use a dropper. And then for the dosage, it's normally 1 milligram per 250 cc, which is 1 milligram per minute, which equals to 15 cc per hour. And this may be given IV, IO, or ET. So the next drug on the list, looking at slide 9, is magnesium sulfate. That's used for Torsades de Pointes or suspected hypomagnesemia, and also for life-threatening arrhythmias due to digitoxin, due to digitalis toxicity. For the dosage, that's 1 to 2 gram diluted in 10 cc D5 water, IVP, even cardiac arrest. If not in cardiac arrest, mix 1 to 2 gram in 50 to 100 cc D5W to infuse over 5 to 60 minutes. Administration may cause a fall in BP with rapid administration. Use with caution if renal failure is present. For morphine sulfate, that's used for treatment of ischemic chest pain, acute cardiogenic pulmonary edema, and anxiety. It decreases the myocardial preload and causes peripheral venous pooling. The doses should be in 1 to 2 milligram increments up to 10 milligram max. Giving slow intravenously over 1 to 2 minutes. The precautions include respiratory depression and hypertension. For Narcan and naloxone, indication is used to reverse respiratory depression that results from narcotics. It's also used for coma of unknown etiology. For the dosages, that's given in 0.4 milligram to 2 milligram IV or IO, maybe given on ET. For the administration, it's normally given in IV or IO meds, which should be given over 1 minute. Precautions: if given rapidly, IV or IO can cause some projectile vomiting. Patient may become agitated or violent. For procainamide, that's used for antiarrhythmic, for stable YQRS tachycardia. For the dosage, that's given in 20 to 50 milligram per minute, and for the administration, that's used for arrhythmia, if arrhythmia is suppressed, if hypotension issues, if QRS duration increases more than 50%, max dose of 17 milligram per kg. For sotalol, that's actually used for hemodynamically stable patients, and also monomorphic ventricular tachycardia and third-line antiarrhythmic. For the dosage, that's given in 100 milligram over 5 minutes or 1.5 milligram per kg over 5 minutes. And for administration, avoid if prolonged QT. The next drug on the list is sodium bicarbonate. We're still on slide number 9. So that's used for pre-existing hyperkalemia, metabolic acidosis, and prolonged resuscitation. For dosage, that's given in 1 milligram per kg IV bolus. Repeat half dose every 10 minutes. Administration not recommended for routine use in cardiac arrest patients. For vasopressin, it may be used as an alternative press or epinephrine in the treatment of cardiac arrest instead of first or second dose of epinephrine. That's given in dosages of IV or IO 40 units intravenous push times 1 dose only. ET, that's given in 80 units times 1 dose only. Administration, that's given 10 minutes after vasopressin is given. Do not give epinephrine for 10 minutes after vasopressin is given. So even though you can give epinephrine, give vasopressin to replace the first and second dose, you do not want to give epinephrine for 10 minutes after vasopressin is given. So I want to discuss the pediatric advanced life supports with you right now. Yeah, so the algorithms include 10 algorithms. You have the pulse systemic approach algorithm. You have the management of shock flow chart. You have the recognition of shock flow chart. You also have the management of respiratory emergencies flow chart, and then the recognition of respiratory problems flow chart, pediatric cardiac arrest algorithm, pediatric bradycardia with a pulse and pulse perfusion algorithm. Then also the pediatric tachycardia with a pulse and adequate perfusion algorithms, and also the pediatric tachycardia with a pulse and pulse perfusion algorithm, and also pediatric post resuscitation care. So the first algorithm that we'll discuss right now, that's on slide 2, will be the pulse systemic approach algorithm, and that's the Pulse systemic approach algorithm outlines the approach to caring for a critically ill or injured child. So for the initial impression, you check if the child is conscious, breathing, or color, or well, you check for the consciousness, for breathing, and also for the color. So is the child unresponsive with no breathing or only gasping? If your answer is yes, then you shout for help, or you activate the emergency response as appropriate for setting. Then the next step is checking for a pulse. If there's a pulse, then you open airway and begin ventilation and oxygen as available. If there's no pulse, then you start CPR. If And then after that, you go to the pediatric cardiac arrest algorithm, and then after the return of spontaneous circulation, begin the evaluate, identify, intervene sequence. If after doing the after opening the airway and beginning ventilation and oxygen as available, you check if the pulse is less than 60 per minute with poor perfusion despite oxygen and ventilation. If that's not the case, if the answer is no, then you want to evaluate for primary assessment, secondary assessment, and also perform some diagnostic tests, which include identify, and then also go to identifying and intervening. Um, then the management of shock flow chart, that includes oxygen, pulse oximetry, and EKG monitor, IV, IO access, BLS as indicated, point of care glucose testing. So these are the needed equipment for the management of shock flow chart. So for hypovolemic shock, there are some specific management for selected conditions. For non-hemorrhagic, that's normally 20 ml per kg normal saline lactated ringer bolus and repeat as needed, and also consider colloid. For hemorrhagic, control external bleeding, 20 ml per kg normal saline or lactated ringer bolus, repeat 2 or 3 times as needed. Transfuse packed red blood cells as needed. For distributive shock, that comes in 3 different types. So that's septic, anaphylactic, and neurogenic. There is a management algorithm for septic shock. For anaphylactic shock, you want to give IM epinephrine or auto injector, fluid boluses, 20 ml per kg normal saline lactated ringer, and also give albuterol, antihistamines or corticosteroids, and epinephrine infusion. For neurogenic, we want to give 20 ml per kg normal saline lactated ringer bolus and repeat as needed, and also give a vasopressor. For cardiogenic shock, that comes in terms of bradyarrhythmia or tachyarrhythmia. Yeah, so we are in on slide 3 right now, and we're discussing cardiogenic shock. So for bradyarrhythmia or tachyarrhythmia, you wanna um, um, the management algorithms include bradycardia, and then tachycardia with poor perfusion. And then for others, which include CHD, myocarditis, cardiomyopathy, and poisoning, um, that includes 5 to 10 ml per kg, normal saline lactated ringer bolus, repeat as needed. Vasoactive infusion, consider expert consultation. For obstetric shock, that includes doctor dependent, left ventricular outflow obstruction, tension pneumothorax, cardiac tamponade, and pulmonary embolism. So for doctor dependent left ventricular outflow obstruction, you give prostaglandin E1 and expert consultation. For tension pneumothorax, you want to do a needle decompression and tube thoracostomy. For cardiac tamponade, you want to do a pericardiocentesis. And then also administer 20 ml per kg normal saline lactated ringer bolus. For pulmonary embolism, you uh, yeah, I want to give 20 ml per kg normal saline lactated ringer bolus, repeat as needed. Consider thrombolytics, anticoagulants, and expert consultation. The recognition of the shock flow chart. The clinical signs for hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. Well, that includes A, B, C, D, E. For patency, you want to make sure that the airway is open and maintainable, and check if it's maintainable or not maintainable. For the respiratory rate, you want to check if the rate is increased. For the effort, you want to check if it's normal or to increase, which is the case for hypovolemic shock and distributive shock, and if it's labeled, which is the case for cardiogenic shock and obstructive shock. For breath sounds, you want to check if it's normal, which is the case for hypovolemic shock, and if it's and also for distributive shock, though you may hear some crackles in distributive shock. For cardiogenic shock and obstructive shock, you may hear crackles and also grunting. For the systolic blood pressure, that actually goes from compensated shock to hypotensive shock. For pulse pressure, it could be narrow for hypovolemic shock, it could be variable for distributive shock, it could be narrow for cardiogenic shock and obstructive shock. For heart rate, it could be increased in all 4 of the types of shock. And for peripheral pulse quality, it could be weak. For hypovolemic shock, it could be bounding or weak in distributive shock. It could be weak in cardiogenic shock and obstructive shock. For the skin, it could be pale or cool in hypovolemic shock. It could be bounding or weak in distributive shock. It could be weak in cardiogenic shock or obstetric obstructive shock. For capillary refill, it could be delayed in hypovolemic shock, it could be variable in distributive shock, and it could also be delayed in cardiogenic shock and obstructive shock. For urine output, it's normally decreased in all types of shock. For the level of consciousness, you could have the patient being irritable, which is an early sign, or lethargic, which is a late sign. For temperature, it could be variable in all 4 types of shock. So for the management of respiratory emergencies flow chart, that includes airway positioning, suction as needed, and oxygen, pulse oximetry, EKG monitor as indicated, and BLS as indicated. For upper airway obstruction, for croup, I will be discussing croup, anaphylaxis, aspiration, foreign body. So for croup, you give nebulized epinephrine and corticosteroids. For anaphylaxis, you give intramuscular epinephrine or auto injector, albuterol, antihistamine, corticosteroids. For aspiration, foreign body, allow position of comfort, and also specialty consultation. For lower airway obstruction, for bronchiolitis, we do nasal suctioning, bronchodilator trial. For asthma, you give albuterol and or ipratropium corticosteroids, subcutaneous epinephrine, magnesium sulfate, and terbutaline. For lung tissue disease, some specific management for selected conditions, which we discuss, which include pneumonia and pneumonitis, and also pulmonary edema. The pneumonia could be, or pneumonitis could be due to infectious chemical or aspiration causes, etiologies. You want to give albuterol and antibiotics as needed. For pulmonary edema, you want to consider non-invasive or invasive ventilatory support with PEP, consider vasoactive support, and consider diuretic. For disordered control of breathing, you want to and that's for increased ICP, poisoning or overdose, and neuromuscular disease. For increased ICP, you want to avoid hypothermia, avoid hypercarbia, avoid hypothermia. For poisoning or overdose, you want to give an antidote if available and contact poison control. For neuromuscular disease, you want to consider non-invasive or invasive ventilatory support. So for pediatric advanced life support, with signs of respiratory symptoms, the clinical signs for upper airway obstruction, lower airway obstruction, lung airway disease, lung tissue disease, and disordered control of breathing. For potency, you want to check if the airway is open and maintainable or not maintainable. For respiratory effort rate or effort, you want to check if it's increased. For breath sounds, you want to check if there's stridor, which is typically inspiratory, with a backing cough and hoarseness. For upper airway obstruction, for lower airway obstruction, you want to check if there's wheezing, which is typically expiratory, and also a prolonged expiratory phase, which is for lower airway obstruction. For lung tissue disease, you want to check if there's grunting, crackles, or decreased breath sounds. For disordered control of breathing, you want to check if it's normal. Then air movement is normally decreased in upper airway obstruction, lower airway obstruction, and lung tissue disease. It's variable in disordered control of breathing. Heart rate, there's normally tachycardia as an early sign and bradycardia as a late sign. Skin, there's normally pallor, cool skin early, and cyanosis as a late sign. The level of consciousness, there's normally anxiety or agitation as an early sign, and there's also lethargy or unresponsiveness as a late sign. So for identification of respiratory problems by severity, that's going from respiratory distress to respiratory failure. So you want to check if the airway is open and maintainable. If it's not maintainable, and it could be it could be open and maintainable in respiratory distress, and in respiratory failure is not maintainable. And then also in respiratory distress, there's tachypnea, there's increased efforts and work of breathing, there's good air movement, there's tachycardia, there's pallor, there's anxiety and agitation. In respiratory failure, the airway is not maintainable. There's bradycardia, bradypnea to apnea. There's a decreased effort, and there's also apnea. There's poor to absent air movement, and there's bradycardia. There's cyanosis, and there's lethargy to unresponsiveness. So for the pediatric advanced life support, some important points include doses and details. So for the CPR quality, you need to push hard more than 1/3 of anterior posterior diameter of chest and fast at least 100 per minute, and allow complete chest recoil. Minimize interruptions and compressions. Avoid excessive ventilation. Rotate compressor every 2 minutes. If no advanced airway, 15 to 2 compressions ventilation ratio. If advanced airway, 8 to 10 breaths per minute with continuous chest compressions. Yeah, so we are at slide 7 right now. The shock energy for defibrillation. The first shock should be 2 joules per minute. Second shock should be 4 joules per kg. And then subsequent shock should be more than 4 joules per kg. And a maximum of 10 joules per kg or adult dose. The drug therapy is epinephrine intravenously or IV, and that's 0.01 milligram per kg, which is 0.1 mil per kg of 1 in 10,000 concentration. Repeats every 3 to 5 minutes. If no IO or IV access, may give an endotracheal dose, 0.1 milligram per kg, which is 0.1 0.1 milliliter per kg of 1 in 1,000 concentration. And then the run IO or IV dose, that's something given as 5 milligram per kg bolus during cardiac arrest. May repeat up to 2 times for refractory VF or pulseless VTAC. For advanced airway, that's endotracheal intubation or supraglottic advanced airway. And then also waveform capnography or capnometry to confirm and monitor ET2 placements. Once advanced airway in place, give 1 breath every 6 to 8 seconds, and that's 8 to 10 breaths per minute. For the return of spontaneous circulation, ROSC, yeah, you want to do pulse and blood pressure, spontaneous arterial pressure waves with intra-arterial monitoring, and also have the reversible causes at the back of your mind, which is the 5 H's and the 5 T's. So that's hypovolemia, hypotemia, hypoxia, hypo or hyperkalemia, and hydrogen ion acidosis, and then the 5 T's, which is tension pneumothorax, cardiac tamponade, coronary thrombosis, pulmonary thrombosis, and also toxins. So we're at slide 7 of the pediatric cardiac arrest algorithm. So the first step is to shout for help and activate emergency response. Start CPR, give oxygen, attach monitor or defibrillator. Check if the rhythm is shockable. If the rhythm is shockable, then that takes you to step number 2. You check if it's V-fib or V-tap, which is normally shockable. Then you shock. Then you give CPR for 2 minutes, IO or IVSS. Then you check if the rhythm is shockable. If it's shockable, then you shock. You do CPR for 2 minutes, epinephrine every 3 to 5 minutes, consider advanced airway. And then at that point you check if the rhythm is shockable, that's 0.6. Then you shock, and that takes you to point 8. So you give CPR for 2 minutes, and then you give amiodarone and treat reversible causes. If the reading is not shockable at each of those points, then you could probably have a patient who has a systole or PEA, um, and then with that you go to point number 10 or 11, and then yeah, you could have a patient who has an organized reading, so you check the pulse. If the pulse is present, then you go to the return of spontaneous circulation or post cardiac arrest care. Um, so if the reading is not shockable, then you could probably have a patient that has a systole or a PEA. So you want to, so with that you go to point 10. So you want to do CPR for 2 minutes. Ensure interosseous or IV access, epinephrine every 3 to 5 minutes, and consider advanced airway. Then check if the reading is shockable. If it is, then you go to step 5 or 7, which is shock, which is administering a shock. Then if it's not, then you want to do CPR for 2 minutes and treat the reversible causes. And then check if the reading is shockable. If it's if it's not, then you go to you consider a systole or PEA, organized reading, check the pulse. If the pulse is present, you do that's return of spontaneous circulation or post cardiac arrest care. So with that, we're gonna go to slide 8. We're talking about pediatric advanced life support on Dr. Chiquito Mentoring Iridescence education collaborative on Ustream YouTube show. So on slide number 8, you want to identify and treat underlying cause. So you maintain a patent airway, assist breathing as necessary. You give oxygen. You hook up on a cardiac monitor to identify the reading, then monitor blood pressure and oximetry. You also want to ensure interruptions and intravenous access. Do a 12-lead EKG if available, and don't delay therapy. And then after that, you check if there's a cardiopulmonary compromise. Check if cardiopulmonary compromise continues. If it does, then you want to do CPR if heart rate is less than 60 per minute with poor perfusion despite oxygenation and ventilation. And then that takes you to the next step on if bradycardia persists. If it does, you want to give epinephrine and atropine for increased vagal tone or primary AV block. Consider transthoracic pacing or transvenous pacing, and also treat the underlying causes. If bradycardia does not persist, then you want to support ABCs, give oxygen observe, and consider expert consultation, which is still the same thing for if cardiopulmonary compromise does not continue. Some important points about this algorithm include, we're on slide 8 right now, include the signs of cardiopulmonary compromise, which is hypotension, acutely altered mental status, signs of shock. For the doses and for the details, you want to give epinephrine IV dose, 0.01 milligram per kg, 0.1 milligram per kg of 1 in 10,000 concentration. You repeat this every 3 to 5 minutes. If IV if IO or IV access is not available, but an endotracheal or ET tube is in place, then you may want to give ET dose, which is 0.1 milligram per kg, 0.1 mil per kg of 1 in 1,000. Atropine IO IV dose, 0.02 milligram per kg, may repeat once to a maximum dose of 0.1 milligram and maximum single dose of 0.5 milligram. Then for the pediatric tachycardia with a pulse and adequate perfusion algorithm, that's slide number 9. Well, you want to identify and treat the underlying cause and maintain the patient airway, assist breathing as necessary. You want to administer oxygen, and also hook up the cardiac monitor to identify reading, monitor blood pressure and oximetry, and a 12-lead EKG if practical. You want to evaluate QRS duration. If the QRS is normal, that's less than 0.09 second, then you want to evaluate the reading. Um, and if and there are two possible outcomes of these of evaluating the reading. If there's probable sinus tachycardia, that could be a compatible history consistent with known cause. P waves present are normal. Variable RR with constant PR. Infants rate usually less than 220 per minute. Children rate usually less than 180 per minute. If there's probable supraventricular tachycardia, you want to yeah, and you want to do a compatible history, which could be vague or non-specific, and then history of abrupt rate changes, P waves absent or abnormal, heart rate not variable, infants rate usually more than 220 per minute, children rate usually more than 180 per minute. If the QRS duration is more than 0.09 seconds, that could indicate possible ventricular tachycardia. So you want to check if there's cardiopulmonary compromise, hypertension, or acutely altered mental status, signs of shock. If those signs are there, then you want to do a synchronized cardioversion. If those signs are not there, then consider adenosine. If the reading is regular and QRS monomorphic, and then you want to do expert consultation, yeah, which is advised. Then you want to give up amiodarone and procainamide. So for the doses and for the details, for synchronized cardioversion, you want to begin with 0.5 to 1 joule per kg. If not effective, then increase to 2 joules per kg, and then sedate if needed, but don't delay cardioversion. Adenosine IV or IO dose, first dose is 0.1 milligram per kg, rapid bolus, maximum 6 milligram. The second dose is 0.2 milligram per kg, rapid bolus, maximum second dose of 12 milligram. Adenosine IV or IO dose is 5 milligram per kg over 20 to 60 minutes. Procainamide IO or IV dose, which is 15 milligram per kg over 30 to 60 minutes. Do not routinely administer amiodarone and procainamide together. So we are at slide number 10, which is the pediatric post-resuscitation care. And we'll talk about some important points, which include estimation of maintenance fluid requirements. So for infants who are less than 10 kilograms, we want to give 4 ml per kg per hour. Example, for an 8 kilogram infant, the estimated maintenance fluid rate would be 4 ml per kg per hour times 8 kilograms. So that will equal out to 32 ml per hour. For children who are 10 to 20 kilograms, you want to give 4 ml per kg per hour for the first 10 kg, plus 2 ml per kg per hour for each kg above 10 kilograms. So for a 15 kilogram child, the estimated maintenance fluid rate will be 4 ml per kg per hour times 10 kg, plus 2 ml per kg per hour times 5 kg. So that will give you 40 ml per hour plus 10 ml per hour, which is 40 ml per hour. So children who are more than 20 kilogram, you want to give 4 ml per kg per hour for the first 10 kilogram, plus 2 ml per kg per hour for kilogram 11 to 20, plus 1 ml per kg per hour for each kilogram above 20 kg. So for example, for a 28 kilogram child, the estimated maintenance fluid rate will be 4 ml per kg per hour times 10 kilogram, plus 2 ml per kg per hour times 10 kilogram, plus 1 ml per kg per hour times 8 kilograms, which is equal to 40 ml per hour, plus 20 ml per hour, plus 8 ml per hour, which is 68 ml per hour. Then following initial stabilization, adjust the rate and composition of intravenous fluids based on the patient's clinical condition and state of hydration. In general, provide a continuous infusion of a dextrose containing solution for infants. Avoid hypotonic solutions in critically ill children. For most patients, use isotonic fluids such as normal saline 0.9 percent sodium chloride or lactated bringers solution with or without dextrose based on the child's clinical status. For the management of shock after the return of spontaneous circulation, the algorithm includes optimizing ventilation and oxygenation. So you want to titrate FiO2 to maintain oxyhemoglobin saturation to 94 to 99%. If possible, win FiO2 if saturation is 100%. Consider advanced airway placement and waveform capnography. And then the next step is assess and treat persistent shock. Identify, treat contributing factors. Consider 20 ml per kg IV or IO boluses of isotonic crystalloid. Consider smaller boluses, example 10 ml per kg if poor cardiac function is suspected. Then consider the need for inotropic and vasopressor support for fluid refractory shock. For hypertensive shock, you want to give epinephrine, dopamine, norepinephrine. For that, for pneumotensive shock, you want to give dobutamine, dopamine, epinephrine, miorenol. Some important points include the possible contributing factors. So you want to do check for the 5 H's and for the 5 T's. So hypovolemia, hypoxia, hydrogen ion acidosis, hypothermia, and hyperkalemia. And then for the 5 T's, which include trauma, thrombins, and tension pneumothorax, thrombosis, cardiac and thrombosis, and pulmonary. And then with that, after assessing and treating the persistent shock, we already talked about the hypotensive shock. So the next one will be the normotensive shock. So that will be and with that, you want to administer the dobutamine, dopamine, epinephrine, and miorenol, and then you now monitor and treat agitation and seizures, monitor and treat for hypoglycemia, assess the blood gas, serum electrolytes, and also calcium. If patient remains comatose after resuscitation from cardiac arrest, consider therapeutic hypothermia. That's 32 degrees centigrade to 34 degrees centigrade. Consider consultation and patient transport to tertiary care center. So that's slide number 11, and we're done with the pediatric advanced life support. We already talked about the various sections, which include the systemic approach algorithm, the management of shock flow chart, the recognition of shock flow chart, the management of respiratory emergencies and flow chart, the recognition of respiratory problems and flow chart, the pediatric cardiac arrest and algorithm, the pediatric bradycardia with a pulse and pulse perfusion algorithm, the pediatric tachycardia with a pulse and pulse perfusion algorithm. No, I'm sorry. The 7th one is pediatric bradycardia with a pulse and pulse perfusion algorithm. Then the 8th one is pediatric tachycardia with a pulse and adequate perfusion algorithm. The 9th one is pediatric tachycardia with a pulse and pulse perfusion algorithm, and the 10th one is pediatric post resuscitation care. So with that, we'll go to fluid replacements. And a very simplified guideline for fluid replacement includes before exercising, 2 to 3 hours before exercise, drink at least 17 to 20 ounces of water or sports drink. Then also 10 to 20 minutes before exercise, drink another 7 to 10 ounces of water or sports drink. What to drink during exercise? Well, drink early. Even minimal dehydration compromises performance. In general, every 10 to 20 minutes, drink at least 7 to 10 ounces of water or sports drink. To maintain hydration, remember to drink beyond test. So just drink as much as you can. That's general advice. Optimally, drink fluids based on amount of sweat and urine loss. What not to drink during exercise include fruit juices, carbohydrate gels, sodas, and sports drink that have carbohydrate levels greater than 8%, which are not recommended as so beverages. 8% carbohydrate is a warning sign. So replacing fluids with a beverage that is less than 8% carbohydrate would be optimal to assure the fastest rate of fluid absorption. Beverages containing caffeine, alcohol, and carbonation are discouraged during exercise because they can dehydrate the body by stimulating excess urine production or decrease voluntary fluid intake. So after exercise, immediately after training or competition is the key time to replace fluids. Weigh yourself before and after exercise. Research indicates that for every pound of weight loss, athletes should drink at least 20 ounces of fluid to optimize rehydration. Sports beverages are an excellent choice. Other helpful hints include using the shade before practice and during breaks. Even during rest, exposure to heat can raise the body temperature, increase fluid loss, and decrease the blood available to the muscles during workouts. Wear loose-fitting clothing. Cotton blend loose-fitting clothing can help promote heat loss. Um, yeah, and the rule is the less clothing, the better. So this is from Helping Educate Athletes in Training, July 2001, and can be integrated into the Let's Move initiative of the First Lady Michelle Obama. So next we talk about more information on fluid replacement. So the overall principles, include listening for the history, examining the patient. Don't forget the ABCs. A is for airway breathing, B is for breathing, C is for circulation, which requires volume. So the faster you're treating the abnormalities, that's the volume or electrolyte, the more often you need to check the patient's progress to reassess the accuracy of your predictions. All calculations estimates. Accuracy of all estimates must be checked by clinical observation of the patients. And then also use fluids which are pre-mixed commercially whenever possible, which include fluids that are less expensive, have less opportunity for error, and are quicker. Become more facile with fluid management will lead to better outcomes. So becoming more facile with fluid management will lead to better outcomes, and this does not have to be difficult. So the maintenance fluids, water is generated in the process of metabolism. So the metabolism procedures, heat regulation requires water. Solute excretion also requires water. So the number 2 point is that metabolic rate is related to surface area and to weight. And then number 3 point is that metabolic rate is kilocalories per day, which approaches fluid need, cc per day. The Holiday Seeger method to calculate metabolic rate for normal patients um, for normal patients include for patients who have a weight of 0 to 10 kilogram, the caloric expenditure in 24 hours should be 100 kilocalories per kg. For those who weigh more than 10 to 20 kilogram, the expenditure should be 100 kilocalories plus 50 kilocalories per kg. For the increments more than 10 10 grams. For those who weigh more than 20 kilograms, the expenditure is 1,500 kilocalories plus 20 kilocalories per kg for increment more than 20 kilograms. Water need is equal to 1 cc water per kilocalorie energy expended. So the maintenance calculation by the Holiday Seagull assumes that fluid losses are normal and equal 1 cc estimated 1 kilocalorie. Insensible loss, we have respiratory 15% of normal, skin 30% of normal, and for urinary losses 55%. Alterations in maintenance requirements, fever is 12% increase for each degree Celsius above 38 degrees. Activity 0 to 30% increase. Tachypnea or hypopnea, anuria, fixed inability to make urine. Um, Obligate polyuria requires more urine to clear each milliosmoles of solid. So very low bed weight infants, you have decreased skin integrity and increased surface area and weight ratio. Maintenance electrolyte requirements, you have sodium 2 to 4 milliequivalent per 100 cc water. You start with 3 milliequivalents per 100 cc. The number 2 point is about potassium. So that's 2 to 3 milliequivalent per 100 cc water. Start with 2 milliequivalent per 100 cc. For chloride, you have 5 to 6 milliequivalent per 100 cc of water. So we have a few examples of calculations that we are gonna discuss in depth coming up on subsequent shows. So the physical examination includes goal number 1 to assess for signs of shock. And shock can be defined as a failure to deliver oxygen and nutrients to tissues. What are the symptoms? You have decreased alertness, poor brain perfusion, decreased urine flow, poor renal perfusion, decreased bowel sounds, poor gut perfusion. Capillary refill time, more than 2 seconds, poor peripheral pulses, estimate degree of dehydration. And sometimes the BP may not decrease, and may actually increase as volume depletion progresses. Estimating the volume depletion can be done on a physical examination by just observing how the patient looks. If there's a 3 to 5% volume depletion, which is defined as mild, you could have the patient looking a lot normal, normal, alert or normal on examination of the affect and mental status, have a normal skin turgor, have a subtle change in their eyes, and also have a normal fontanelle. In moderate, which is 6 to 10%, you could have the patient being irritable or obtunded. That's on observation of the affect or mental status. A decreased skin turgor. They could also have a sunken eyes and sunken fontanelle. On severe, and then also in terms of the urine, for mild, they have a high specific gravity, decreased volume, moderate, very high specific gravity and scant volume. For severe, they could also have more than 10%, which is having and then on physical examination, you can observe that the patient will have a very decreased skin turgor. They will have sunken eyes, and they will also have a sunken fontanelle, and the urine could be dark, muddy, or they could have little or no urine. So looking at slide number 3, and talking about physical examination of fluid fluid depletion. For mild, you could have the blood pressure and the heart rate could be increased or very high. For moderate, it could be no for mild and moderate, it could be increased or very high, and um, for severe, um, it could be low or very high. Then for the peripheral pulses, it could be normal for mild, it could be weak for moderate, it could be not palpable for severe. For estimated deficit volume for mild is 30 to 50 cc per kg. For moderate is 60 to 100 cc per kg, and for severe is more than 100 cc per kg. These symptoms will overestimate dehydration if the patient is hyponatremic, and also if the patient is hypernatremic. So that's the factors that you have to consider. To prescribe fluids, you have to calculate and give the maintenance fluid, adjust for individual differences. Then also you also want to integrate the deficit replacement fluids estimated from the physical examination and history type of loss, and also replace for any ongoing loss for any ongoing losses. Example: continued diarrhea or NG tube drainage. Point number D is readjustment after lab values are known and after follow-up confirms or alters your estimates. When the patient is more than 3 to 5% dehydrated, always check the electrolytes immediately. Point number 5 is choosing a rate of fluid administration. If the patient is poorly perfumed, then that is there are symptoms of shock. Give 20 cc per kg of isotonic fluid as rapidly as possible. Repeat as necessary to establish perfusion. Next, choose a rate and composition which will replace the deficit early in the 24-hour period, that's 48 hours. Use available fluids. So half the deficit plus half the maintenance over 8 hours, then the remaining half deficit and half maintenance over the next 16 hours. Or the whole deficit over 8 hours and then the whole day's maintenance over 16 hours. But the plans may need to be changed once the electrolyte values are known. The replacement of potassium and bicarbonate may take longer than the replacement of volume. Do not start potassium replacement until the urine flow is established. So the next slide, which is on slide number 4, has a list of all the available intravenous fluids. We have isotonic fluids and the components: normal saline, Ringer's lactate, 5% albumin. Other fluids: D5 water, D5 water, water saline, water normal saline, D5 water, half normal saline, 25% albumin, 5% sodium bicarbonate, and 8.4% sodium bicarbonate. Hypotonic saline, 3% sodium chloride, and 5% sodium chloride. The table has a list of the components of glucose, sodium chloride, potassium, of all these fluids. And then there's a calculation also that you can also be able to work on to practice these how to integrate these in real life situations. So whenever IV fluids or oral rehydration fluids are administered for dehydration, reassess the physical examination and also the vital signs to check the accuracy of your predictions. The faster the rehydration or the more severe the fluid or electrolyte abnormality, then the more often the patient needs to be reassessed. So I'm going to slide number 5, which is on oral rehydration. This is best used in the absence of shock. When poor perfusion is present, isotonic fluid bolus can restore perfusion, then oral rehydration can proceed. Glucose is actively absorbed and sodium is co-transported across the gut mucosa. Works even in most forms of diarrhea. Optimal glucose transport concentration um, at concentrations is glucose 2 to 2.5 gram per meal, sodium 45 to 90 milliequivalent per liter. Higher glucose concentration will exacerbate diarrhea and sodium loss. Next is a table that has the contents of available rehydration solutions of the World Health Organization, ORS, Pedialyte, Rice Light, Lecithin, Ginger Ale, apple juice, Gatorade, and tea. So the instructions for oral rehydration is advisable to use the World Health Organization ORS or a commercial preparation for rehydration. That is to replace the deficit over 4 to 6 hours. Then use breast milk or other lower sodium maintenance fluids for the rest of the day. Use more ORS to continue to replace ongoing losses. Restart feedings as soon as possible. Lactose free is also advisable. Also, cautions about oral rehydration. This should not start until shock has been treated and reversed. Some patients, less than 10%, will need some IV prescriptions due to vomiting or high volume stool. All patients require monitoring. That means physical examination and serial weight, just as with IV rehydration. Improper mixing of fluids can lead to hydrogenic fluid imbalance. Some ORS do not taste great. Hyponatremic dehydration. Hyponatremia is seldom symptomatic unless the serum sodium is less than 120 and occurred quickly. Very rapid correction of very low sodium has been associated with central pontine melanosis in adults, which is also usually seen in malnourished alcoholics, although reported elsewhere. Hyponatremia can cause seizures when it's severe and sudden. Um, some 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 people recommend correction, but that's still under investigation. So slide number 6, the consensus is to correct low sodium quickly only when it's compromising the patient, then correct it only to 120 milliequivalent per liter. When there's clear dehydration with low serum sodium, the symptoms may overpredict the degree of deficit. So the more severe symptoms at 5% loss than if on normal natremic. There's a calculation calculating the sodium deficit, which are things that you will see in real life situations. For hyponatremic dehydration, that's managed when serum sodium is more than 150 milliequivalent per liter. So first is to establish perfusion, reverse shock if it's present. Initial treatment of poor perfusion or shock is done as always. Rapid bolus normal saline alkaloid 10 to 20 cc per kg, which is repeated if necessary, usually in progress before electrolytes are known. Point number B is subsequent replacement of the deficit, which is done slowly. Goal is to decrease the serum sodium no faster than 0.5 to 1.0 milliequivalent per hour. Check to make sure that there are no factors elevating serum osmolality. You can measure serum osmolality directly, or estimate serum osmolality, which is 2 sodium plus glucose over 18 plus BUN over 2.8. If other factors are elevating serum osmolality, they must be treated slowly as well. Even though the deficit is predominantly water, it's safer to use fluids no more dilute than 34 milliequivalent per liter sodium. That's 1 saline to replace the deficit. And the rationale for this is that water moves freely across all cell membranes, including the blood-brain barrier. When serum sodium is elevated for more than a few hours, the brain cells generate idiogenic osmoles to maintain intracellular tonicity and size. Idiogenic osmoles are not diffusible or transportable out of the cells. So going to slide number 7, we're talking about fluid replacement. Sodium decreases of extracellular sodium concentration will cause water to enter the CNS cells, suddenly causing cerebral edema. And calculating the water deficit, assume that the deficit is all free water. That is, there is no sodium deficit. Assume that total body water, TBW, is approximately 0.5 times weight, kg. The water deficit in liters is equal to TBW times the measured serum sodium over 140 minus 1. So I have an example right here, which I'll discuss briefly. A 10-kilogram child who has a serum sodium measured at 180 and has a history of diarrhea, vomiting and dehydration with a home brew containing of table salt and water of unknown composition boiled. The total body water will be 0.5 times the weight, which is 10 kilogram, which is 5 kilogram, which is 5 liters. The water deficit will be 5 liters times 180 over 140 minus 1, 5 liters times 1.3 minus 1, which is 5 liters times 0.3, which is 1.5 liters. So planning the fluid resuscitation, yeah, I'm still on slide 7. You want to re-establish perfusion, you want to give maintenance fluids, you want to spread the water deficit replacement out over 48 to 72 hours, giving us 1 quarter normal saline. You want to check the electrolytes frequently at first and then regularly until serum sodium is back to less than 150. So the abnormalities of potassium, potassium is mainly intracellular. That's 90% of total body potassium is intracellular. Intracellular fluid potassium concentration is 150 milliequivalent per liter. Intravascular potassium accounts for only about 5% of total body potassium. So the potassium balance intake is normally by nutritional or intravenously. Internal shifts, we have anabolism, potassium is taken up into cells. Cellular uptake is regulated by insulin or aldosterone or beta agonist. The second point is 3 milliequivalent per liter of potassium is required for each gram of protein. Catabolism, potassium is released into extracellular space. Cell injury, sodium or potassium ATPase, is slowed. Potassium is released into extracellular space, and point number D is pH shift. So potassium for potassium and hydrogen experiences balance changes. In acidosis, potassium leaves the cells. In alkalosis, potassium enters the cells. Excretion, renal depends on depends on the glomerular filtration rate, but it's mainly a secretory function. For extrarenal, you have GI and sweat. Total body potassium and serum potassium are not closely correlated. It's impossible to predict accurately the size of a potassium deficit. 1 milliequivalent per liter decrease may reflect 10 to 30% loss of total body potassium. So I'm going to slide 8. The relationship of serum potassium to EKG changes, the changes that you notice on EKG interpretation. The first point, it depends on the total body potassium deficit or overload. So when the serum potassium is less than 3.0, you normally notice EKG changes of flat T waves, prominent U waves, and ST depression. When it's 7.0, you notice peaked T waves. When it's 7.0 to 8.0, you notice prolonged PR intervals. When it's 8.0 to 9.0, you notice widened QRS and absent P wave. When it's more than 9.0, you notice wider QRS and VFib or arrest. Now, these changes can occur at lower serum potassium if intracellular potassium is low. So let's talk about hypokalemia. Some causes include decreased intake. So the renal losses include intrinsic defects, example Bartter syndrome. Diuretics include thiazides and loop diuretics. Number 3 point include renal response to GI, chloride losses and volume depletion. Number 4 include hyperaldosteronism. Number 2 include consequences of muscular weakness, paralysis, and respiratory failure. Number 4 include loss of renal concentrating ability, vacuolization of tubular cells. Number C includes myocardial conduction abnormalities and exacerbation of digoxin toxicity. Treatments, replacement of potassium may take longer than volume replacement. Care should be taken not to allow worsening of hypokalemia during volume resuscitation and during correction of the electrolytes. The total amount of potassium deficit will not be known until the acid and base abnormalities are fixed. Um, and also correction of acidosis may or usually will worsen hypokalemia. Results of attempts at replacement are known. I also noticed during these procedures. I have a calculation on slide 8, which actually reflects which is a calculation about the water deficits and also the sodium and potassium maintenance. So slide number 9, it's on hyperkalemia. So what are the causes? Increased load, catabolism, dietary or iatrogenic. Decreased excretion, so that's renal failure, adrenal insufficiency, potassium sparing diuretics, other renal abnormalities without adrenal abnormalities. Status post transplantation, obstructive neuropathy, sickle cell disease, pseudo hypoaldosteronism, internal shifts, acidosis and acidemia, rhabdomyolysis, very vigorous exercise, familial hyperkalemic paralysis, drugs, succinylcholine, or digoxin overdose. Consequences that we have on cardiac and neuromuscular. The severity depends on extracellular potassium level and intra and extracellular potassium ratio. More severe, lower serum levels if the intracellular potassium level is lower. So the treatment is a three-phase approach. You stabilize the membrane effects. Calcium gluconate, normally 10%, 0.5 to 1.0 ml per kg as an IV slow push. Or calcium chloride 100 milligram per ml, 0.2 cc per kg. Dose intravenously into a central or large vein, which has been reported to burn skin on contact. So that's a side effect that you may actually notice. And the effect is immediate with a duration of 10 to 15 minutes. Um, and it may need to be repeated during the episode. Point number B is shift potassium into the cells. So sodium hydrogen carbonate, 1 to 2 milliequivalent per kg, may need more if there's a big deficit. The effect normally occurs within 5 to 15 minutes, duration up to 2 hours. It's advisable not to mix with calcium-containing solutions to flush the line if the patient is hypokalemic, may cause tetany and contributes to sodium overload. Um, Glucose, to induce an endogenous insulin surge, you want to do 5 to 1.0 gram per kg over 15 minutes. Effect in 15 to 30 minutes, duration of 4 to 6 hours. If insulin is needed, use 3 units regular per gram glucose given over 2 hours. Beta agonist, albuterol inhaler by nebulizer or MDI, effect with 1.5 effect within 1 to 5 minutes with a duration of 1 to 2 hours. Doesn't require access but may increase the heart rate. So remove potassium from the body, increase the GFR and tubular flow rate, volume expansion. Diuretics, you have furosemide 1 milligram per kg IV. So that takes us to slide 10. Um, and this is useful only if renal function is demonstrable. Onset varies from minutes to level, duration is permanent. Um, Caecilate enema can be administered as a 1 gram per kg mixed in sorbitol 5%. Onset over 2 hours, duration is permanent. If used as a PO, the effect takes much longer, up to 6 to 12 hours. Exchanges 1 milliequivalent per kg for 1 milliequivalent sodium has caused bowel perforations in some immediately post-operative patients. So that's some fluid replacement. We'll go to the next one. There are actually four of them. Yeah, so I'm going to the next um, um, information on fluid replacement. It's titled Intraoperative Fluid Management and Blood Transfusion Essentials. So the body fluid distribution. Yes, I apologize for the breaking transmission. The body fluid distribution includes 25 liters of intracellular water, 5 liters of intravascular water, and 15 liters of interstitial water. So the pre-operative fluid stressors normally include being NPO, that means nothing per mouth or nil per mouth, status pre-op, intra intraoperatively and postoperatively. Patient's primary disease causes intravascular fluid depletion. Some conditions like trauma or bleeding, bowel disorders, obstruction or diarrhea, hyperglycemia with osmotic diuresis, diabetes insipidus or poorly controlled hypertension and chronic use of diuretics are potential stressors. Um, and the patient's primary disease causes of intravascular fluid excess, poorly controlled congestive heart failure, renal failure overdue for dialysis, or preeclampsia can lead to hypovolemia or hypervolemia. Hypervolemia. Preoperative nausea or vomiting delays the resumption of PO fluid intake. The intraoperative fluid losses can be obvious or subtle. If it's obvious, that could lead to bleeding in surgical field. Subtle, that could be evaporative losses from exposed peritoneal surfaces. Sequestration of fluid in extracellular space, also called dead spacing. Sympathectomy from spinal or epidural anesthesia. So calculating the fluid deficit, fluid requirements for normal adults. You have fluid per hour, 60 ml plus weight in kg minus 20 ml, which probably plateaus at 90 to 100 kilogram body weight, so not more than 140 ml per hour. The deficit is calculated based on hours of NPO status. So 8 hours NPO for a 70 kilogram patient will be 8 times 60 plus 60 plus 960 ml. So an 80 kilogram patient who has been NPO for 8 hours is almost 1 liter behind before anesthesia and surgery. Replace prior to anesthetic induction. Probably okay, but most would replace half of it then and replace the second half over the first hour thereafter. There's no definite gold standard. The maintenance fluid, the hourly basal fluid requirement is approximately 100 to 140 ml per hour for most adults. So you want to add in blood loss, the crystalloid replacement, balanced salt solutions, 3 to 4 ml of crystalloids per 1 ml of blood loss, colloid or blood product replacement, 1 ml of solution per 1 ml of blood loss. Dead spacing, this is a controversial subject. The concept is that local trauma causes edema to develop, and that this edema does not maintain the usual connection between interstitial and intravascular spaces. The greatest dead space losses normally occurs in open laparotomies, 4 to 6 ml per kg per hour, possibly open thorax with inflamed pleura, perhaps 2 to 4 ml per kg per hour. Not a big consideration for superficial, that's breast or skin or peripheral hand, foot, or knee procedures, which normally is 0.2 ml per kg per hour. Some believe that the dead spacing concept is overrated and has given anesthesiologists an excuse for overloading patients with fluids. So is dead spacing overrated? Well, there's probably is some dead spacing, but assumed dead space formulas for fluid losses have been too high. Example, maybe it peaks at 3 to 4 mil per kg per hour, and maybe only when the ball serosal surfaces are fully exposed. Some have assumed as much as 8 to 10 mil per kg per hour under these conditions, which is too high. Recent studies suggest that conservative fluid management improves outcomes with colon and pulmonary resections. Others are still yet to come. So the rational fluid management plan for a 70 kg man undergoing an open small bowel resection who has been NPO for 6 hours. Fluid deficit, that's 110 ml per hour times 6 hours is equal to 660 ml. So you want to give approximately 350 ml of lactated ringer pre-induction. Over the first hour, you want to give a maintenance of 110 ml plus remaining deficits, which is approximately 300 ml plus approximately 4 ml per kg per hour that space deficit. That's 280 ml, which is 690 ml. The rational fluid management plan for a 70 kg man undergoing an open small bowel resection who has been NPO for 6 hours. So for 7 hour, assume 100 ml blood loss, maintenance 110 ml plus dead space loss. That's 280 ml plus 4 times 10 ml to replace blood loss, which is equal to 790 ml. If the bowel is not fully exposed to the room, that's maybe if it's in a bag or if it's sequestrated intra-abdominally, then decrease the dead space assumption. Laparoscopic approach greatly decreases the dead spacing, probably 2 ml per kg per hour or less. Also, urine, and don't forget, urine output counts in the fluid loss category to replace one-to-one with crystalloids. Crystalloids, approximately 25% remains intravascular 1 hour after administration, even less with D5 water, less than 10%. Typically, normal saline or balanced salt solutions are used intraoperatively in adults. Balanced salt solutions, you have lactated bringers or normal salt, which is similar to plasma light. For the crystalloid composition, fluid, you have D5 water, 0.9% normal saline, lactated bringer. So D5 water contains no sodium chloride or potassium. 0.9% normal saline contains 154 of sodium and chloride respectively. And then lactated bringer contains 130 of sodium, 109 of chloride, and 4.0 of potassium. Normal so R contains 140 of sodium, 108 of chloride, and also 5.0 of potassium. The crystalloid composition fluid, the various fluids for D5 water, the osmolality is 252 for D5 water. The pH is 4.5. 0.9% normal saline has an osmolality of 308. pH has an osmolality of 6.0. For lactated bringer, it has an osmolality of 273 and a pH of 6.5. And then it contains lactate 28, calcium 3. Normal cell R has an osmolality of 294, pH of 6.6, and order of magnesium 3 and acetate 27 and gluconate. So which crystalloid to select? D5 water, seldom used but makes sense as background maintenance for diabetics, insulin, children and adults undergoing long cases, that's more than 6 to 8 hours. It's a bit useless for intravascular volume replacement. Normal saline makes sense if the patient is hyperkalemic, hyponatremic, hypochloremic, or if slight hyperosmolarity is desired. That's for craniotomies. Not so good if avoidance of metabolic acidosis is important. So which crystalloid to select? For lactated ringer, what cause solution in most ORs? Avoid if hyperkalemic or hypocalcemic tends to induce mild alkalosis. Normal sol R is similar to lactated bringer. Magnesium is a plus. Absence of calcium allows mixing with secreted blood products. For special solution situations, we have bonds. So the Parkland formula is a very good formula for bonds. So that's 2 mil per kg percent body surface area bond over first 8 hours, 0.25 mil per kg percent bond per hour. The same amount over next 16 hours, 0.125 mil per kg percent BSA body surface area per hour. Calculation for 80 kg patient with 50% BSA bond coming to the OR for debridement 12 hours after injury. So that's 0.125 times 80 times 50, which is 500 ml per hour for bond alone. Don't forget maintenance, blood loss, possible febrile states, increased fluids and urine outputs. So we are on slide 21 right now, and that's our introduction to transfusion, RBCs, fresh frozen plasma and platelet concentrates. So the blood component production, there's an algorithm here illustrating whole blood, the process of producing the various types of blood products, including packed red cells, fresh frozen plasma, cryoprecipitates. So I want to, and it's a very useful algorithm, which is very useful in understanding the various products. So the therapeutic dilemma um, um, for anemia, it, um, it increases mortality, it decreases quality of life, it jeopardizes organ viability, especially in presence of limited collateral or vasodilatory reserve, critical coronary or carotid stenosis. For transfusion, independent association with decreased mortality and morbidity, immunosuppression and enhanced inflammation may be the culprit. Glucose reduction may actually help. Immediate augmentation of oxygen transport may be limited. That's 2,3 dPg deficit, and also infectious complications. So some infectious complications of transfusion in virus infections and diseases. For HIV, the risk in most of USA is 1 in 800,000. HTLV 1 or 2 is 1 in 600,000. Hepatitis C is 1 in 600,000. Hepatitis B is 1 in 200,000. Cytomegalovirus is 1 in 100. Other infectious complications of transfusion include viruses. So you have West Nile, 1 in 26,000 estimates, CJD, which is rare, bacteria, which is unusual, but as high as 1 in 1,000 platelet concentrates are usually fatal. Parasites, you have malaria, babesiosis like malaria, and Chagas disease with regional variation, even in USA, but are rare overall. So one never knows what new and unsuspected virus is lurking in the blood supply. Hepatitis C went virtually undetected for almost a decade at an incidence of 4% per unit transfused. Um, Immunologic complications of transfusion, mild and relatively common, urticaria, febrile reactions, generic immunosuppression, not necessarily mild, as associated with cancer recurrence and infections. Serious and uncommon, you have ABO, RH incompatibility, non-ABO antibodies. Hemolysis often delayed. Trial can be fatal. Anaphylaxis usually the recipient has an IgA deficiency. So we are on 27 on slide 27 right now, talking about the metabolic complications of transfusion. Citrate intoxication, FFP given very fast is most common cause. Treatment is calcium chloride. Hyperkalemia, older RBCs typically, the treatment is hyperkalemia. Hypokalemia, metabolic acidosis, metabolic alkalosis. Hypothermia if RBC warming is ineffective, not an issue with fresh frozen plasma or platelets. So the most important transfusion predictor, pre-operative hemoglobin or hematocrit. Um, Anemia in elective surgical patients. Expert panel evaluating best practices. So the first recommendation, recommendation one, elective surgical patients should have hemoglobin level tested a minimum of 30 days before scheduled surgery. Um, recommendation two, unexplained anemia should be considered secondary to some other process, and elective surgery should be deferred until an appropriate diagnosis is made. So there's an anemia diagnostic workup, which illustrates the various pathways for the various types of anemia. Um, so good luck at all. Yeah, I recommending that we diagnose and treat anemia pre-operatively. Does this seem like like rocket science? No, but it's seldom done by surgeons and anesthesiologists. Why? It's often impractical. It depends on surgical urgency, access to patients pre-op, timing of access to patients pre-op. Clinical settings where pre-op diagnosis and prescriptions of anemia works or doesn't. It works. Elective total joints, elective cardiac valve replacement or repair, spine fusions or scoliosis repairs, most radical hysterectomies or radical prostatectomies. It doesn't work or is it needed? Urgent CABG, fast growing cancers, even though elective procedures where transfusion is unlikely. The ASA practice guidelines. Transfusion is rarely indicated when hemoglobin is more than 10 grams per dl. Transfusion almost always indicated with hemoglobin less than 6 grams per dl. Levels between 6 and 10, it depends upon the situation. Use of a universal transfusion trigger is not recommended. So don't be trigger happy. Transfusion trigger isn't just a numerical threshold. Consider patient performance markers, tachycardia, fatigue if awake, myocardial ischemia, EKG and TEE. If increased susceptibility, LVH, CAD, cerebrovascular disease, hyperthermia, hypermetabolic states, burns, sepsis, evidence of global oxygen delivery failure, SVO2, PVO2, and lactic acidosis. RBC transfusion modifiers. Primary anemia compensation is increased cardiac output. So this fails if the heart can't increase CO, bad valve disease, severe diastolic dysfunction, dilated cardiomyopathy, etc. You can't maintain normal volemia, rapid blood loss. In these situations, hemoglobin 8 to 9 may be a good trigger point for RBC transfusion. How about algorithm for bleeding and coagulopathy, which it illustrates the various workup for coagulability and what to do with the yeah, if there's hypothermia, if there's PT, PTT, fibrinogen, and platelet counts. Um, so indications for fresh frozen plasma. Correction of microvascular bleeding with elevated PT or PTT more than 1.5 times normal. Correction of congenital or acquired factor deficiencies that lack specific concentrates. Urgent reversal of warfarin-induced anticoagulation. Rare exchange transfusion for autoimmune diseases. Angioneurotic edema, C5a deficiency. Non-indications, fixed ratio to RBC transfusion and malnutrition. FFP, so misunderstood the Dr. Pepper of most blood products. Most over transfused blood components most over transfused blood components problem exacerbated by lack of rapid turnaround on PT and PTT testing. And yet, when FFP is truly needed, many docs underdose it. The usual starting dose for microvascular bleeding with elevated PT is 10 to 15 ml per kg, that is 4 to 6 units in most adults. Fibrinogen concentration versus blood volumes lost is similar for other factors. So there's a graph here that talks about the various factors. So platelet transfusion indications, non-surgical patients, the platelet counts less than 20,000, some say 10,000. Surgical patients, the platelet count less than 50,000 pre-operatively or intraoperatively. Platelet dysfunction, as in after cardiopulmonary bypass, potentially needed if the platelet count is 100,000, but seldom if higher than that. Um, Platelet transfusion would help in heparin-induced thrombocytopenia, a hypercoagulable state exacerbated by platelets, TTP, PTO. ITP, the circulating antibodies just eat the transfused platelets. Risk is more than the benefit. May not help if there's unbound clopidogrel or accessimil in the plasma. Um, Platelet transfusion dosing usually starts with 0.1 units per kg. Platelet count should increase by 10,000 per unit. Check the size of a pooled platelet pack at your hospital. Ranges from 4 to 8 units, and folks often mistakenly call these 1 unit of platelets locally. On single donor platelet pheresis used for high risk recipients, 1 pheresis is about the same as 6 to 8 pooled units of random donor platelets. So next we'll talk about the last fluid fluid resuscitation. That's fluid resuscitation 4. So I have a very good article, a 4-page article about maintenance fluids and electrolytes. The primary focus for intravenous fluid replacement is to provide for a child's maintenance and deficit fluid needs. Maintenance fluid needs are met by replacing fluids and electrolytes through normal body processes, for example, metabolism and respiration. Deficit fluid needs are met by replacing the fluids and electrolytes lost before therapy began. Additional fluids may be needed to replace abnormal losses that continue during therapy, for example, persistent vomiting, diarrhea, or nasogastric tube drainage. The daily maintenance fluid needs, the daily maintenance fluids are those needed to replace insensible fluid losses from the skin and the lungs. Urine and stool losses that result from normal metabolism. Um, so there are many nomograms and other tables that help you determine maintenance fluid needs. Generally, these calculations are based on an estimate of a child's body surface area, body weight, or calories expended. The most common method for calculating maintenance fluids in the Holiday-Seeger method, which is based on the child's body weight. This method converts the caloric requirements of a child into free water requirements. It relies on the principle that one milliliter of water is spent for each calorie a child uses. Therefore, fluid needs can be determined directly from the caloric expenditure. Infants have higher caloric requirements per kilogram than older children. This method divides caloric and therefore free water needs into 3 categories based on body weight, as described in the table below. So the table below is titled Scale Daily Maintenance Fluid Needs, which are for the various weights and fluid needs per 24 hours. So for a newborn, 0 to 72 hours, the fluid needs per 24 hours is 60 to 100 ml per kg. For a newborn who is 0 to 10 kilogram, that's 0 to 22 pounds, the fluid needs is 100 ml per kg. 11 to 20 kilogram, 24 to 44 pounds needs 1000 ml plus 40 ml per kg for more than 10 kilogram. For more than 20 kilogram, that's more than 44 pounds. needs 1,500 ml plus 20 ml per kg, more than 20 kilograms. So I have some calculations that are very useful, that will help to illustrate this. I will talk about that coming up next week. The 4-2-1 rule, the 4-to-1 rule simplifies and speeds up the calculations. The IV fluid rates are written per hour rather than per day. Although you can divide the daily total by 24 to get the hourly rate, this can be difficult to do in your head. As it is for the authors of this book, the 4-to-1 rule closely approximates the log route. So consider that 1,000 ml per kg per day per 24 hours is equal to 4.2 ml per kg per hour, close to 4. 50 ml per kg per hour per day per 24 hours will equal out to 2.1 ml per kg per hour, close to 2. And 20 ml per kg per hour in 24 hours will equal out 0.8 ml per kg per hour, close to 1. So with that, we'll go to pediatric fluid replacement. It's a six page handout, and I'm gonna share it for you. It's titled Guidelines for Pediatric Born Resuscitation. So the purpose is to provide standardized orders and a protocol for the University of Michigan Born Services regarding pediatric born patient resuscitation in the intensive care unit. The recommendations are also included for different fluid resuscitation and hypertension. Definition: this protocol applies to all pediatric cutaneous born patients. Prior to initiating the protocol, an assessment of the patient's TBSA burn must be performed, including only partial and full thickness burn injury using the rule of 9 diagram. Obtain the patient's weight or close estimate in kilogram. The resuscitation guidelines, the first one include first 24-hour post-burn. So the endpoint is for total body surface area of less than 20%. Maintenance IV fluid until patients taking adequate oral intake. The B point is total body surface area more than 20% and weight more than 30 kg. Calculate estimated intravenous fluid needed. 2 to 4 ml of lactated Ringer times body weight times percentage total body surface area burn. Administer half of calculated volume over the first hours post-burn. So the IVF rate is 2 to 4 ml of lactated Ringer times kilogram body weight times percent TBSA burn over 2. An IVF already given. So that's giving a meal over 8 hours minus time since injury in hours. The C point is administer the remaining half of calculated volume over the subsequent 16 hours. Then IVF 16 rate is equal to 2 minus 4 ml of lactated Ringer times kg body weight times percent total body surface area burn over 2 over 16 hours. At the 9-hour mark, take the IVF rate at 8 hours and divide by 2. Then use the greater of the two calculated rates. That's the IVF 16 rate or IVF rate as the hour 9 IVF rate. Now, if the patient's urine output is less than 0.5 ml per kg per hour, usually 30 ml per hour, then increase the infusion of lactated Ringer by 33% of the hourly calculated fluid requirements. If the patient's urine output is more than 70 ml per hour, then you dip the urine dipstick to exclude glucosuria. Decrease the infusion of lactated ringer by 33% of the hourly calculated fluid requirement. Do not decrease IVF rate below 125 ml per hour. For total body surface area more than 20% and weight less than 30 kg, calculate the estimated intravenous fluid needs. 3 to 4 ml of lactated ringer times kilogram body weight times percent total body surface area born. Administer half of calculated volume over the first 8 hours post-born. IVF rate is equal to 3 to 4 ml of lactated ringer times kilogram body weight times percent total body surface area over 2 minus IVF already given in meal per 8 hours minus time since injury in hours. Then point number C, administer remaining half of calculated volume over the subsequent 16 hours. With IVF 16 rate is equal to 3 to 4 ml of lactated ringer times kilogram body weight percent times percentage total body surface area born over 2 over 16 hours. At the 9-hour mark, take the IVF rate at 8 hours and divide by 2. Then use the greater of the two calculated rates of IVF 16 rates or IVF rate as hour 9 IVF rate. Then point number E, in addition to born fluid requirements, also infuse a maintenance IVF at 4 ml per hour for the first 10 kilogram body weight, 2 ml per hour for the second 10 kilogram body weight, and then 1 ml per hour times remaining kilogram body weight. If the patient's urine output is less than 1 ml per kg per hour, then increase the infusion of 33% of the hourly calculated fluid requirement. If the patient's urine output is more than 1 ml per kg per hour, then deep urine to exclude glycosuria. Decrease the infusion of lactated ringer by 33% of the hourly calculated requirements. Do not decrease the total IVF rate below the calculated maintenance of rate in ml per hour. In patients who are less than 2 years of age, use D5 lactated ringer to avoid hypoglycemia. Place the anterior feeding tube as early as possible in all patients with burns more than 20% TBSA. After 12 hours after burn injury, assess IVF administered. I apologize for the breaking transmission. Place enteral feeding tube as early as possible in all patients with burns more than more than 20% total body surface area. Point number F, at 12 hours after burn injury, assess if IVF administered, assess the IVF administered and calculate the projected 24-hour total IVF if fluid rates are kept constant. If the projected 24-hour IVF requirement exceeds 6 ml per kg percent total body surface area burn, then switch to the difficult fluid resuscitation guideline. So on page number 3, we are still on page number 3. Um, point number 2 is 24-hour post-burn. Check serum sodium and potassium every 6 hours on the second burn day. Point number B, adjust the type of fluid by the serum sodium level. Point number C, if after 24 hours the IVF rate remains high, consider switching to 5% albumin. Point number D, goal is to decrease IVF rate to half of rate infused over the previous 16 hours. We'll have to estimate based on patient size, percentage burn, response to resuscitation, and estimated losses. Attending input is recommended. If the patient is more than 30 kilograms, the urine output goal is 0.5 ml per kg per hour, usually 30 cc per hour with a maximum of 70 ml per hour. If the patient is less than 30 kilograms, the urine output goal is 1 ml per kg per hour, maximum 2 ml per kg per hour. So point number 3 is the treatment of low urine output. So A, if urine output falls below lower limit for 1 hour, then increase current IVF infusion rate by 33% of the calculated hourly requirements. Point number B, if urine output falls below lower limit for second consecutive hour, increase current IVF infusion rate by another 33% of the calculated hourly requirements. Point number C, if the urine output remains below target for third consecutive hour, notify the house officer. Then point number D is if urine output exceeds the upper limit for 1 hour, dipstick of urine shows no glucose present, then decrease current IVF infusion rate by 33% of the calculated hourly requirements. For patients with burns more than 20%, starts of total body surface area, starts oxandrolone 10 mg PO BID. For patients with burns more than 20% total body surface area, starts beta blockade with PO metoprolol. So for on slide number 4, that's difficult fluid resuscitation guidelines. So point number 1 is switch the intravenous fluid to 5% albumin. So that's isotonic premix 5% albumin, or 200 milliliters of 25% albumin in 800 milliliters, 0.9 normal saline at the previous crystalloid IVF rate. Point number 2 is to check the bladder pressures every 4 hours. Point number 3 is if the urine output is less than 30 ml per hour in a more than 30 kilogram patient, or less than 1 ml per kg per hour in a less than 30 kilogram patient, then strongly consider monitoring central venous pressures from a subclavian or IG line along with central venous saturation. That's a goal of SVP of CVP 8 to 10 mm mercury, SvCO2 60 to 65%. If CVP not at goal, then increase the fluid rate by 33%. If CVP at goal, then consider the glutamine 5 microgram per kg per minute. Titrate until CVO2 at goal. The max dose of the glutamine is 20 microgram per kg per minute. If both CVP and CVO2 at goal, then stop increasing fluids, even if the UOP is less than target. The patient should be considered hemodynamically optimized. The oliguria is likely a result of established renal insult. Some degree of renal failure should be tolerated and expected. Continued increases in fluid administration despite optimal hemodynamic parameters will only result in resuscitation morbidity that is oftentimes more detrimental than renal failure. If the patient becomes hypotensive along with oliguria, UOP less than target, then follow the hypotension guidelines. Point number 5, every attempt should be made to minimize fluid administration while maintaining organ perfusion. If UOP more than 70 ml per hour and patients more than 30 kilograms, then decrease the fluid rate by 33%. If UOP more than 2 ml per hour and patient is less than 30 kilogram, then decrease the fluid rate by 33%. Do not decrease below the maintenance of IVF rate based on the patient's weight. After 24 hours, infusion of lactated bringrad should be titrated down to maintenance levels, and 5% albumin continued until the 48-hour mark. For hypertension guidelines, the optimal minimum blood pressure for born patients must be individualized. Some patients will maintain adequate organ perfusion and thus have adequate UOP at MAPs lower than 70 mm mercury. True hypertension must be correlated with UOP. If a MAP generally less than 55 mm mercury is not adequate to maintain the UOP goal of 30 ml per hour, then the following steps are recommended. Step number 1, start with vasopressin 0.003 units per kg per minute drip. Do not titrate. Monitor CVP goals of 8 to 10 mm mercury. If CVP not at goal, then increase IV fluid rate by 20 to 33%. If CVP at goal, then add Levophed, norepinephrine. Start at 0.02 mcg per kg per minute with addition of a second vasoactive agent. Would consider stress dose hydrocortisone at 2 mg per kg per dose every 8 hours. Maximum dose of 100 mg per dose for 48 hours and then reassess. If additional pressors are needed, consider guiding resuscitation with specific SVO2 goals, SCVO2 of 60 to 65%. These patients may be volume depleted, but a missed injury should be suspected. If CVP not at goal, then increase IV fluid rate 20 to 33%. If CVP at goal, then consider epinephrine starting at 0.02 mcg per kg per minute and titrate to effect. If hypotension persists, look for missed injury and initiate stress dose hydrocortisone. Consider adding norepinephrine as a last resort. Now, if the patient is exhibiting catecholamine resistant shock, consider the following diagnoses: missed injury and ongoing blood loss. B. Acidemia. If pH is less than 7.20, adjust the ventilator settings to optimize ventilation with a target PCO2 of 30 to 35. If despite optimal ventilation, patient still has a pH of less than 7.2, consider bicarbonate administration. Point number C, adrenal insufficiency, start hydrocortisone 2 mg per kg IV every 8 hours. Maximum dose of 100 mg per dose. Hypokalemia, maintain ionized calcium for more than 1.1. So some points at the appendix include flex domain, 25% contains 12.5 gram albumin and 145 plus or minus 15 milliequivalent liter of sodium in 50 liters. Lactated bringers contain 130 milliequivalent per liter. And then point number 3 includes 0.9 normal saline contains 154 milliequivalent per liter. Point number 4, to make a 5% albumin solution, you remove 200 ml of 0.9% normal saline from a 1 liter bag and add 4 bags or 200 ml of flex domain, 25%. So I have a calculation here that illustrates this, which is very useful about illustrating this very important point. And we just talked about guidelines for pediatric fluid resuscitation. So with that, we'll go to the next point, which is coding and billing, which is a very important aspect that you experience in medical school with more responsibilities as a resident and also in practice. And that's something that is part of the ACGME core competencies. So I have a very useful algorithm here, which is the 1997 Evaluation and Management Guidelines at a glance. It has two tables, one for the new patient and one for the established patient. So for the new patient, you have a code 99201, 99202, 99203, 99204, 99205. So these are the 5 codes, and they all vary based on the history, the exam, the decision making, and also the time. So for the 99201, which is for a new patient, the history should be problem focused, the exam should be problem focused, and the decision making should be straightforward within 10 minutes. For 99202, the history should be expanded problem focused. The exam should be expanded problem focused. The decision making should be straightforward in 20 minutes. For 99213, the history should be detailed along with the examination with a low complexity decision making within 30 minutes. For 99204, the history should be comprehensive along with the exam, and with a medium complexity decision making within 45 minutes. And then for the 99204, the history should be comprehensive, and the exam should be comprehensive, and then the decision making should be high complexity within 60 minutes. Now for the established patients, the codes are 99211, 99212, 99213, 99214, 99215. So the history for the 99211, the history should be the history exam and the decision making actually does not really count, and that's all within 5 minutes. For the 99212, the history and exam should be problem focused, and the decision making should be straightforward within 10 minutes. For the 99213, the history should be expanded problem focused, along with the examination, and then with a low complexity decision making within 15 minutes. For the 99214, the history should be detailed along with the exam, and with a medium complexity decision making, all within 25 minutes. For the 99215, the history and exam should be comprehensive with a high complexity decision making, all within 40 minutes. So for the exam, for the problem focused, the 15 bullets that are recognized by the E&M guidelines. Um, 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 yeah, so that's all part of the physical examination, which have to be integrated in deciding whether the physical examination is problem focused, whether it's expanded problem focused, whether it's detailed, or whether it's comprehensive. So if there are an exam of 1+ system or areas, then that's problem focused. On bulleted elements of 1 to 5, that's problem focused. On expanded problem focused, that's 1+ system areas and 6 to 11 bulleted elements. Detailed is 2+ with 12+ bulleted elements. Comprehensive is 9+ with 18+ bulleted elements. Now, quick points to note is for the comprehensive exam, all bulleted elements in the 9+ systems or areas examined must be performed. So the constituents of the general multi-system examination include constitutional, any 3 vital signs, the general appearance of the patients. For the eyes, include inspection of the conjunctiva and the lids, the examination of the pupils and the irises, ophthalmoscopic examination of optic disc and posterior segments, the ears, nose, mouth, and throat. So that includes the external inspection of the ears and nose, otoscopic examination of external auditory canals and tympanic membranes, assessment of hearing, inspection of nasal mucosa, septum and turbinates, inspection of lips, teeth and gums, examination of the oropharynx, oral mucosa, salivary glands, hard and soft palate, tongue, tonsils and posterior pharynx. For the neck, includes the examination of the neck, the examination of the thyroid. For the respiratory, includes assessment of respiratory efforts, the percussion of the chest, the palpation of the chest, and the auscultation of the lungs. For cardiovascular, it includes the palpation of the heart, auscultation of the heart with notation of abnormal sounds and murmurs, and also the examination of the carotid arteries, abdominal aorta, femoral arteries, pedal pulses, extremities for edema with or without varicosities. For the chest, that's the breast, include inspection of the breast, palpation of breast and sedum. For the gastrointestinal abdomen, includes the examination of the abdomen with the notation of presence of masses or tenderness, and the examination of liver and spleen. And also the examination for the presence or absence of hernia, the examination of the anus, perineum, and rectum, including the sphincter tone, the presence of hemorrhoids and rectal masses, and also obtains two samples for occult blood tests when when indicated. And then for the genital urinary, for the male, examination of the scrotal contents, examination of the penis, the digital rectal examination of the prostate gland. For the female genital urinary system includes pelvic examination, including the external genitalia and the vagina, urethra, that's examining for any masses, tenderness or scarring, um, the bladder, the cervix, the uterus, and also the adnexa or parametra. For the lymphatic, includes palpation of lymph nodes in two or more areas, which includes the neck, axilla, groin, or other. For the musculoskeletal, includes the examination of the gait and station, inspection of and palpation of the digits and nails, examination of joints, bones, and muscles of one or more of the following six areas. That's the head and the neck, the spine, the ribs and the pelvis, the right upper extremity, the left upper extremity, the right lower extremity, and the left lower extremity. The examination of a given area includes inspection or palpation with notation of presence of any misalignment and asymmetry, crepitation, deficits, tenderness, masses, or effusions. And also assessment of range of motion with notation of any pain, crepitation, or contracture. And then also the assessment of stability with notation of any dislocation, subluxation, or laxity. And also the assessment of muscle strength and tone with notation of any atrophy or abnormal movements. For the skin, includes the inspection of the skin and the subcutaneous tissue, the palpation of the skin and subcutaneous tissue. For the neurologic, include testing the cranial nerves with notation of any deficits, the examination of deep tendon reflexes with notation of pathologic reflexes, and the examination of sensation. For the psychiatric, includes a description of the patient's judgment and insight, a brief assessment of the mental status, including orientation to time, place, and crossing, recent and remote memory, and then mood and affect. So going back to slide number 1, which contains information about the history. So classifying it into problem focused, expanded problem focused, and detailed and comprehensive. For the problem focused and the expanded problem focused include 1 to 3 history of present illness, and then the review of system and the past family and social history elements do not count in expanded problem focused and the problem focused, but detailed. Uh, but, but for the detailed, the history of present illness should include more than 3 or more chronic diseases. Two with That's for the detailed and for the comprehensive. And then for the review of system should include 2 to 9 of the review of system, and also more than 9 of the comprehensive. And then one component of the past family and social history, and also two for established patients, and three for new patients. Um, and the HPI includes location, quality, severity, duration, timing, context, and modifying factors, associated signs and symptoms, or status of chronic diseases. The review of system includes constitutional, eyes, ears, nose and throat, cardiovascular, respiratory, GI, GU, musculoskeletal, chest, skin or breast, um, neurologic, psychiatric, endocrine, hematologic, lymphatic, allergic or immunologic. The past family and social history is also part of elements of the history. The next slide, which is slide 2 of the coding and building. I hope you're looking at it. We are talking about the GME core curriculum components currently, and um, and the quantification of risk of complications, morbidity, and mortality. For minimal risk level, that includes one self-limited minor problem with some diagnostic procedures of venipuncture, chest X-ray, EKG, urinalysis, ultrasound, echocardiogram, and potassium prep. Um, and then and then The management options include rests, goggles, elastic bandages, and superficial dressing. For low risk level include problems of more than one self-limited or minor problem, one stable or chronic illness, acute or complicated illness or injury. With diagnostic procedures of pulmonary function test, barium enema, superficial needle biopsy, arterial puncture, and skin biopsy. Um, Management options of over-the-counter drugs, minor surgery, no risk factors, PT, OT, fluids without additives. Moderate risk level include problems of one plus chronic illnesses with um, mild prescribed side effects, more than one stable chronic illnesses, new problem, no diagnosis, example, a breast lump, acute illness with systemic symptoms, example, pyelonephritis, acute complicated injury, example, head injury with brief loss of consciousness, moderate, that's diagnostic procedures, cardiac stress test, fetal contraction stress test, yeah, diagnosis of endoscopy with or no risk factors, deep needle or incisional biopsy, arteriogram, lumbar puncture, thoracentesis. And then management options of minor surgery with risk factors, um, prescribed drugs, IV fluids with additives, closed closed management of fracture or dislocations without manipulation. High risk level of problems of one plus chronic illnesses with severe um, prescribed side effects, potentially life-threatening problems. Example, acute MI, um, progressive severe um, rheumatoid arthritis, potential threat of suicide, abrupt neuro change. Example, seizures, TIA weakness, or sensory loss. Diagnostic procedures include diagnostic endoscopy with risk factors, management options including bacterial controlled substances, prescription needing intensive monitoring for toxicity, and DNR decision. So for the decision making, um, which goes in stratification